Yes, sir, you can start recording. Good afternoon, every participant. I think everyone has joined, but without spending any time, then I'll start. Some of you are known to me. Some of you are quite regularly doing my courses. Sir, I'm audible?
Yes, sir. Yes, sir.
Yeah. So Mayuri, she is known to me. She has been my student. I think Mahindiran, he also joined last class of mine. And others I'm not able to see. Probably they'll be joining in some time. Yeah, thank you so much. So today we are here to learn about electrotherapy. Electrotherapy in physical rehabilitation. So I'm not sure uh, what are you doing? Like Mayuri, I know he's a student. So like I need a small introduction from all of you so that I can go in that level in my class. Can I have a small introduction? Starting from Lal
Yeah.
Krishnan. Yeah, please.
Yeah. Could you please switch on your video and then you can
Yes.
give intro.
Okay. Okay. Patient from Kerala. Fine. You can switch on your video and then come. Also, you can verbally speak to me. That will be even better for me. Yeah, Dr. Aswini.
Hi, sir.
Yeah,
I'm
please.
Ashwini. Actually, I'm into cardiorespiratory pediatrics and
Okay.
adult. Presently, I'm on maternity break. I just
Okay.
wanted to explore more in that.
Okay.
Electrophysiology, electrophysiotherapy,
Okay.
uh, how we can apply in cardiorespiratory also. Just
Okay.
wanted to know.
Okay.
Because they also have some pain due to post-surgical pain and all. So,
Correct.
in correct way, we have to apply it. So I'm
Well,
there in past practicing in there for past 5 years.
okay. Well, good to know. Actually, Aswini, last time I was having I think last Sunday I was having class on
But
cardio
I
physio.
was not able
In
to
that
make payment
not a
on
problem.
that. That's the
Okay.
reason I was not able to attend on that.
Not a problem. In that, there was a small part like how do we attach the electrotherapy with the cardio respiratory part. So cardio respiratory part, I am having a few page, 1 or 2 page, like kind of tips and techniques and which all kind of, electrode placement or something. I'll try to add up in the PDF format and then post in the group so that you can have fair information how you apply cardio in cardio cases like post abdominal thoraco-abdominal surgeries and taking care of in season. So those part. Yeah.
Okay.
Yeah, Jobin. Listening. I think Jobin is not online till now. Mahindiran. Okay. Cool.
Sir, good evening, sir. I am
Yeah, good
Mahendran.
evening. Yeah, how are you, Mahindran?
Yeah, fine, sir.
Yeah, please go ahead.
Sir, I am working as a teaching faculty in PhD College of Physiotherapy, Coimbatore.
Achha. Okay, cool.
I have attended your last
Yes,
class.
I know very well. So I thought that you are finally a student. I did not know that you are working as a lecturer. Sorry.
It was very useful, sir.
Yeah.
Very informative lecture. So only I
you.
immediately joined in electrotherapy also.
Fine, I'll try to make today's things also quite interactive, but only thing is that we can't, today we can't have that sort of demonstration because, those many machines are not possible to bring and a few of the machines are not actually allowed in many countries due to some of the contraindications. So we will be going quite slowly and then we will be knowing what is the basics behind all electrotherapy and what is the parameters, what is the idea behind choosing the parameters. So once you know that, you are
Sure,
master
sir.
of going that. Yeah, cool. Dr.
Sure,
Sapna.
sir. Thank you, sir.
Thank you. Dr. Sapna, listening?
Yes, sir. Good evening,
Yeah.
sir.
Good evening.
I am a third year student of Bachelor of Physiotherapy.
I just saw it. Yeah, I just saw that. Yeah.
Yes,
Yeah,
sir.
good. Which college you are in?
Sir, I'm from Chaudhry Charan Singh University, that is
Meerut.
situated in Meerut right
Yeah,
here.
I know.
And
Okay. Which college?
from Prakash Institute of Physiotherapy
It's in
in Greater
Meerut?
Noida.
Greater Noida. Okay.
Yes, sir.
Okay. So what is the idea behind joining? I think second year you would have finished the electrotherapy, right?
Yes, sir. Electrotherapy first part has been finished by me. Electrotherapy second part is there in third year. And I
Okay.
just want to explore some more information about how to apply electrotherapy there in physiotherapy in various conditions such as coma or paralysis or any other conditions.
Only about like electrotherapy in physical rehabilitation, it will be detailing about different current, like what is the biophysics, how do we apply
Yes, sir,
everything.
surely.
But according to the condition, we'll be coming and I'll be asking on the case history at about 7:30,
Okay, sure,
7:45.
sir.
Then we'll have a better discussion about it. No problem. Okay,
Okay,
Dr.
sure, sir.
Rajiv. Yeah, thank you so much. Dr. Rajiv Gogoi, a quite senior, listening. Okay. Okay, I think Rajiv sir is not online. Good. Fine. Dr.
Hello.
Okay, Dr. Vaishnavi Suresh.
Hello.
Yeah, hello.
Dr. Rajiv.
Hello.
Okay. Yeah,
Hello,
please
sir.
tell. Please tell, sir.
Hello, sir. I'm Rajiv Gogoi.
Yeah, please tell.
Yes, sir. So actually, I passed out 10 years back, but not into this profession. Actually, now actually I was thinking to open my own clinic. So just for refreshment.
Okay, good, good, good. Okay, very good, very good.
Yeah, one more is left. Lalit
One more.
Yadav.
Yes, that's what I was looking for. Yes, Dr. Lilith, can you listen?
Hi, sir.
Yeah, please.
Yes, sir.
Yeah, please explain something about you so that I can understand.
Sir, my story is same like Gogoi, sir.
Okay.
I also completed my BPT nearly 6 years ago and joined some other work, and now I am looking again to start it. So,
Okay, good. Look, I want to say you and Rajiv sir, since you are quite senior, it is never too late. So it's a matter of choosing, day one or one day. So I think now after passing, I mean, you have decided to choose day one. So let us start today.
yes,
Yeah,
sir.
yeah. Thank you so much, all the participants. It was a wonderful interaction about introductory part. Let's start.
Good evening, sir. My name is Vaishnavi.
Yeah, I was missing. Yeah, this name only I was missing. Yes, yes, yes. Please go ahead.
Very good evening, sir. My name is
Very good.
Vaishnavi,
Yeah.
and I have completed my master's in July 2020 in orthopedics manual therapy. I've done it from Manipal, Bangalore.
Okay.
And previously, I've even completed the sports internship as well. So
Okay.
I practice equally in manual therapy and sports. And
Okay.
very recently, I've been certified as a women health physiotherapist and a counselor.
Okay.
I've completed that course as well.
Good.
So the agenda behind me being interested in this course is that definitely in second year, we have all explored about, we have been taught about electrotherapy, no doubt. But
Yeah.
when it comes to masters, what I, experienced was, it's all
Yeah.
completely evidence-based now and also to be kept updated. So
Yes.
we can start moving and we can walk into our profession forever only if we are updated.
Yeah.
So
Fine.
like in the light of the recent events when I was doing my masters, when we
Okay.
were searching a lot of evidences and articles, what
Okay.
I found was like we were never taught about electrical stimulation with the needles, or place the electrodes, attaching the electrodes to the
Okay.
needles,
Okay.
or many other things like that.
Okay.
And
So
I
look.
also found that, sorry sir.
Yeah. Yeah. Please complete yourself.
So I also found recently that electrotherapy is used a lot into the women's health as well, which is not at all explored in our bachelor life.
Yes.
So I thought like if we don't use it, we lose it. So now we can see that there are many slimming centers and fitness centers. They just use 24 electrodes, Faraday current, and use them for slimming, who are not even physiotherapists. So when we have the governance over the electrotherapy, when we are, graduated with those subjects, I thought
Yeah.
we can know more, so that we can
Yes.
apply it in our clinical application with precision.
Yes. Quite nice. The thing is like Dr. Vaishnavi, that the electropuncture, what you were talking about, electro needling and all those things, that
Yes,
has
sir.
to be taught by the specialist. That is the hands-on training. So we don't give those kind of training, like because on the online today, in today's course, we'll be detailing about, say, for example, current. So what type of current? Why do you use it? Where do you use it? And why, and what is the parameter you are selecting for, certain conditions for pain reduction? Why are you selecting this? So once you know about it, then you will be knowing like how it is being used. I know there are a lot of slimming center, they are using 22, 24 electrodes and lot many things they are doing without knowing a lot of evidence about it. So today's part I have prepared with help of more than 10 books, and according to, gone with the more than I can say that more than of my 11 to 12 years of clinical experience too I have attached. So you please go through this, and then when we will have the hands-on training in electrotherapy later after the corona pandemic, then definitely we will see much more things which is not possible online to do. Fine. I'm Saurav Shandilya. I'm in
Sure,
charge of
sir.
academics at, yeah, thank you. I'm in charge of academics and strategy at My Rehab Academy. I'm co-founder of Sankalp Physical Therapy in Bangalore. Today's part is electrotherapy in physical rehabilitation. I have shared the screen. I hope everybody is seeing. So there'll be the learning outcomes, like four basic learning outcomes will be seen today. First is the basic concepts and foundation. Then is the modalities, biophysics, and clinical application. Then third will be rationale behind using modalities. And case studies and question hours, of course, we will see at last. The thing is, basic concepts and foundation like electric current, charge, these all things you have seen right since the school days. Okay, but what is the biophysics behind that? If you are using a hot pack, why are you using? How much hot are you using? If you are using a gel pack and if you are using a ice cubes, what is the difference? So today's electrotherapy will change your approach toward the patients. Next is rationale. Why are you using? How are you using? And after that, why are you using? So there are a lot of, all 5 W's and 1 why. So all WH questions today, and then case studies, quite interesting later. So this course is something for the people who are opening a clinic and then they don't know like what to do immediately. So whatever the basic machine they are going to start in the clinic, we are talking about that. Hope once the corona pandemic goes, then definitely we'll catch each other, and then we'll have a lot of discussion on the modern machines too. So today I'll be explaining you about the PEMF technology also. This is quite modern and this is quite different. So that will be the last part. First, let us start the basic concepts and foundation. We'll be learning about why therapeutic agents. We say these electrophysical agents like a therapeutic electrophysical agents or TPH in healthcare. Use of these agents is widespread in the field of physical therapy, physical medicine, athlete training, chiropractic, and sports medicine. As Dr. Vaishnavi just told, we do have governance on these things, but still, like the people who doesn't know much about it, but still they are using it. So we should be very clear that in year 2011, WCPT, the World Confederation of Physiotherapy, earlier it was World Confederation of Physical Therapy, admitted another subgroup in area of its organization, that is ISEAPT, that is International Society for Electrophysical Agents in Physical Therapy. The purpose of this society is to promote the worldwide usage of these electrotherapy machines by providing education materials as well as the related information and news on this subject of interest, and to, of course, to its members. So we have certain division about classification of therapeutic electrophysical agents. How do we divide it? So let us divide like a thermal, that is thermotherapy, cryotherapy, hydrotherapy. Then it comes to mechanical, spinal traction, limb compression, continuous passive motion, ultrasound, extracorporeal, soft wave therapy. Then it is electrical. You all know electrical stimulation. Then it is a TENS. Then it's electrical stimulation for tissue healing and repair. I'll be explaining you what it is. Then iontophoresis. We have kept a separate division and discussion for this. Then it is electromagnetic part like shortwave diathermy, low level laser therapy, and ultraviolet. Today we will not be able to see these part very seriously because this needs a lot of hands-on training, and then it needs the machines to describe like how do we use it. Even for like shortwave diathermy, many countries it is not permitted, and low level laser therapy also many people they have doubt on this. So of course ultraviolet, it is something that where the hospital has to use it. So I had one torch, I can say you the ultraviolet UVB torch that has to be used for the skin, but still it has lot of formalities to be done through the doctors, then only you can use these things. So evidence-based clinical decision-making protocol. Before starting this, I'm telling you, there are people who actually fool on, like fool the physios, especially junior physios, in name of evidence-based. But you should not be deterred about it. Look, evidence-based, when we say, that means we have done certain certain types of experimentation upon the subjects, upon the patients over the period of years. So what is happening here? If you go through the book of Low and Reed, Electrotherapy Explained, I'm not sure how many of you have read that book, but that book has lot of evidence given with the subject. So when you read about the normal subject, just to pass your exam, of course, and then when you know about the kind of what I'm saying you, the kind of evidence they have given, that is bit different. I mean to say, you'll be surprised to see they have given the evidence for the bone healing. They have given the evidence for the tissue repair. I mean to say that ACL repair. They have given the evidence about lot more things which you feel, oh, electrotherapy can work like this. Yes. So it is your tool. It is something to support you. I never say people that like use only electro or use only manual. You use, these all are your tools. So once the patient comes, you should know where to use what and how to use which machine or which technique. So say for example, then how do you make this clinical decision? So I have given you this, 7 points. You don't have to take any what do you say, the photo or anything, because I'll be sending you the manual to all of you that will have all these things properly. So you can just go through this. What do? You formulate the case history. Of course you do that. And then you online the look. The second point is not for you. This is something for the people like who has formulated this protocol according to their countries, this one. Then you go to the online therapeutic goals and outcome measurements. Means those countries, those day only, like some 5 years before only, they had to feed up all the online details. So you actually make the goals and what all measurements you expect. Then justify the use of these electrotherapy machines based on evidence-based practice. Okay. Next is outline the key intervention of parameters. Then you go for the reporting pre and post intervention outcomes. Now you document the case intervention using your normal SOAP. Okay. No, I mean to say subjective, objective, assessment, and then plan. Then now we will be starting about some basic ideas how the things goes, like soft tissue healing process. You should be knowing about the soft tissue healing process right from the second year. You have studied all these things, but still, just to learn about it, how electrotherapy plays important role in this. I have given even the what we say beautiful image. You can go through that. The innate capacity of the body to heal itself is remarkable, but most of the time it is limited and imperfect if you don't take care. Okay, so now healing of soft tissues rests on 4 overlapping phases. It is never demarcated well. Always remember: homeostasis phase, body's emergency response to pathology, of which the aim is to prevent hemorrhaging, usually span over seconds to minutes. Then inflammatory phase, you know very well, inflammatory phase. Then it comes to proliferative phase, concerned with formation of new and immature tissues. Just a minute, I'll check the chat box. Is there anything? Yeah, proliferative phase, concerned with formation of new and immature repair tissues, happen in weeks or months. Remodeling, maturation phase, the last phase, what we learn in pathology, is concerned with the alignment and just concerned with the alignment and strength of repair tissues happen within months or years. So this thing has to be definitely seen by you very seriously. Okay, this is how it matters. So tissue healing occurs via regeneration and repair mechanism. You know very well. Qualities of soft tissue healing may be defined as ideal, acceptable, minimal, and of course failed. I mean to say, you can see, for example, of a malunion. What happens in that case? Okay, or maybe the contracture tissue. What happened in that case? Then it is skin, bone, and skeletal tissues. Muscles have best healing due to their better vascularization. And all these electrotherapy machines are used to enhance the soft tissue healing process by targeting its specific phases. Okay, so you should know which phase what to use. Now this is our very basic image. You see homeostasis, what happened? It could happen in few hours. Okay, so here what happens, the coagulation. In this case, what happened? Platelets and fibrin goes higher in the number. Then it actually enter into the inflammation. So of course, immune response will come. Infiltration, debris clearance, pathogen killing, especially neutrophils and later lymphocytes. These all come into the picture. After that, proliferation. Proliferation, very, very important phase. Today you will be saying why sir is explaining about this pathology. But let me tell you, this is very important. When I'll be talking about PMF device, I'm telling you those devices definitely work according to all these phases. So you should know which electrotherapy part you are going to use for which particular phase of the kind of what we say, the soft tissue healing process. So proliferation, fibroblast proliferation, scar formation, collagen synthesis, angiogenesis, in this case proteoglycan, fibroblast, collagen, these all comes into picture. Then it starts the remodeling. But again, I'm telling you, it's an overlapping phase. So remodeling could start much before the proliferation finish. So don't be confused about it. It's the overlapping process always. Next is epithelialization. I mean, the new epithelial tissues come into the picture. Then again, it's overall remodeling by scar maturation and contraction. Then of course, apoptosis also happens. How many of you know about apoptosis? How many of you know about apoptosis?
It is the time cell that
Programmed cell death.
Is the literal meaning? Yeah, definitely yes.
If
Anything
any
else you know about?
macrophage enters our body, the normal cell division will get disturbed, and one cell will itself will go for its cell death. That is apoptosis.
Okay,
That
fine,
is the
very good.
programmed cell death.
Yeah, very good, Mary. So the thing is, you know, there is something called switching on and switching off mechanism. Do you know about it? Have you any idea about it? Switching on and switching off mechanism? No. Okay. So the thing is, in normal, you know, like whole body cells, we have something called the switching on and switching off mechanism. If you learn more about it, I mean, of course, we don't have much time about it, but just I'm telling you as a like a home task, you can go and you can just learn about it. You know, there is a person, I'm missing his complete name. He was awarded Nobel Prize just for discovering these things. Okay, switching on and switching off mechanism. So we never know how cells switch on again. So this switching on and switching off mechanism in between many of the cells, like the apoptosis, we say that it's a programmed cell death. Somebody told, I think Sapna, she told. So programmed cell death. How? Which all factors program it? There are more than 5,000 chemicals inside one single cell. So there are a lot of complex process through which one cell is programmed to death. Okay, one cell can stay without nucleus, but can it stay without protein? No, because life is not without protein, right? So there are a lot of things inside this, like DNA, RNA, translation, transcription, lot of things about it. So you should know these all phases of soft tissue healing is overlapping. It's never a well demarcated. It's not like homeostasis started. Kindly mute yourself so that others won't get disturbed. Yeah. So it is not like the homeostasis get finished, then inflammation starts. Nothing like that. The proliferation can start much before the inflammation part get finished. The remodeling start, you know, like much before the proliferation get finished. So it's an overlapping process. As a physio, you must understand. Now, as a physio, you should have your idea where to apply which agents. So after this, understanding the pain. It's a quite unpleasant sensory and emotional experience associated with actual or potential tissue damage, of course, or described in terms of such damages. It may not be the actual or potential tissue damage, but it may be described in such damage. I'll let you know how it is. Now, this puzzle of pain revolves around the fact that pain may occur without injury, you know, without injury also, a biologic purpose, or injury without pain. A biological purpose also can be served that is purely without injury. So pain may be acute and chronic, as every one of you know, but it doesn't fulfill any useful purpose most of the time. Now, pain may be, I have categorized pain into 4 parts, okay, in general, as per electrotherapy nature. So nociceptive, neuropathic, psychogenic, or carcinogenic. So pain is a four-dimensional process revolving around, at least you remember, when you see electrotherapy, you should be knowing the four things easily: intensity, quality, effect, and location. This is four-dimensional stuff. Now let us discuss about one by one these pain, because unless you understand the pain, you will not be able to choose your device or type of device, in fact. So nociceptive pain, the pain which arises from actual damage to non-neural tissue and activation of nociceptors. Nociceptors are kind of receptors which are high threshold sensory in nature. Okay, it is part of the somatosensory nervous system that are capable of transducing and encoding noxious stimulus. Okay, now noxious stimulus, we say that that actually has potential to threaten or damage the normal tissues. Okay, so nociceptive pain you must understand very, very concise and clear manner. Okay, somatic pain, that that generally arise from the of course nociceptors, but these nociceptors are found in most of the body tissues but not in the nervous tissues. Okay, it results primarily from the pathologies like glass cut injury or trauma or any sort of chronic disease, or mostly after the surgery. Suppose there is a what we say thoracoabdominal incision. So this kind of pain will be saying the somatic pain. It is said that this is the most common kind of pain, and it matches the type of stimulus. I mean to say, if somebody is like pinching me, I'll be able to tell, yeah, of course it was a pinch. Okay, somebody is poking needle to my skin, I'll be able to tell, yes, it was like a needle kind of stuff. So it respond very well with your device. Okay, so these kind of pain, you must use your device. It will work really well. Now come to visceral pain. You know what? Visceral pain results from activation of nociceptors, of course, because it is also a type of nociceptive pain, but they are found in the viscera, and you can't find out the location easily. Disease is the main cause. Disease is the main cause rather than injury. It is frequently perceived as referred pain. You would have seen the referred pain, right? Everybody understand about referred pain, right? The pain is received at some distance from the site of affected organ. We say that viscerosomatic convergence, one of the nature of I can say that sensation. So what happened here? So basically the sensory neurons from the viscera connects brain via a sensory pathway that carries information from the muscles and skin. So brain interprets the nociceptive input originating from the diseased organs coming from these tissues, okay, rather than the actual tissue. Let us take example of angina. What happened in angina? It's quite perceived in left part of the chest, right? The chest pain, which actually kind of referred in nature, and then I can say that radiating in the nature. The pain comes to shoulder, to elbow, even till wrist, right? And upward it goes to upper trapezius region, and then it goes to many a times it goes between the scapula, isn't it? Isn't it? So, which corresponds to cutaneous supply of C3 and T5. Clear? Yeah, it was a dermatomes and myotomy story. So that's what I'm saying, which corresponds to cutaneous supply between C3 and T5. So these all having a nociceptive afferents from the heart center, heart, which actually enter into the spinal cord through dorsal root of C3 and T5 only. Okay, so disease of lung, liver, or kidney are largely painless, until functioning becomes severely impaired. We can't know about it, but minor lesion in bladder or abdomen could be more painful. Clear about it? So visceral pain, we never know the origin. It's all about because of these nociceptors are not actually placed in that way in sensory pathway. It looks like it comes from the muscle, but it is not. So here, with somatic pain, which is the major pain, in that the part of the nociceptive pain, we are stopping our discussion, and let us talk about how do we differentiate. Okay, because I'm coming up with one of the very interesting topic called like the approach, an approach toward the symptoms of cardiovascular disease. Okay. So today, let us talk about 2 minutes, just 2 minutes or 5 minutes. How do you differentiate the different kind of pain? Okay. So I'm giving you one example of cervical spondylitis, number one. Second is angina. Third is gastric ulcer. Fourth is fourth is GERD. Everybody, I hope that you know about GERD. Okay, so how do you differentiate about these pen? Anybody has any clue?
Sir, angina will be like the throbbing pain, and gastric ulcer will be, we will have the burning sensation of the pain.
Okay.
And, which one you said, sir? Other than angina and this? Cervicogenic.
Yeah, I mean the cervicogenic, cervical spondylitis I asked.
Cervical spondylitis. So usually the person will have pins and needles sensation in their legs when they wake up in the morning.
Legs? Is it legs?
Hands.
Okay. Anything else? Anybody? No. Okay. No problem. You are correct, but we have to have some more differentiation. What happened many a times, you get confused between, suppose a person having somewhere near the fourth intercostal place, I mean there is a pain. Okay, somebody came to my clinic about 3 days before and he was saying that sir, I'm having pain in fourth intercostal, I mean this area. So I actually examined, it was between fourth and fifth. So I just found out, okay, fine. So you know what happened, he was more and more worried about he may have got some problem with the heart. Okay, but when I asked him something, then he said yes, it is correct. What happened, you know, he kept his mobile as well as his keys and he slept without knowing it. So it was hurting that particular part. Got my point? So most of the time, musculoskeletal injury to the intercostal space will not be radiating in the nature. Everybody got it? Everybody got it?
Yes, sir.
You got it? So what happened, these
Yes.
kind of people, you say, do you have any breathing problem? No, I'm absolutely fine. Okay, nowadays if you ask anybody that do you have any breathing problem, they think that they are the corona patient. I mean, you are suspecting them as a corona patient. It doesn't happen most of the time, but yeah, they suspect like this. So that is one part. Okay, so if their pain is not radiating and with the proper deep breathing also, the pain is having a difference in intensity, but it is not moving here and there, that means what? That means it is a pure musculoskeletal injury. It has happened here. Okay, now come to the corona, because it is a hot topic everywhere nowadays. Do you know that pulmonary fibrosis is one of the complications of corona? Have you received any such patient, or did you know about it? The problem is there that chest wall problem, I mean the chest wall pain in some of the region could happen because of corona. I mean the post-COVID cases, it can happen. So you should have your beautiful what we say manipulation technique and mobilization technique, where actually you try to go for the more and more manipulation and make your patients easy to go with the day-to-day normal life, that you can make it. That's not a big problem unless they are metabolically balanced. Well, now we will be talking about neuropathic pain. Okay, so neuropathic pain, after this basic chapter we'll have a quick break of just 5 minutes, then we will be back. So neuropathic pain is caused by a lesion or disease of the somatosensory nervous system. Of course, it is often characterized by an array of abnormal painful sensation after becoming chronic, like allodynia. Okay, so it can be again divided into two categories: peripheral and central. Peripheral basically results from the pathologic function of peripheral nervous system. Okay, due to injuries to peripheral nerves, you would have seen the glass cut injury, or you would have seen the road traffic accident. After that trauma, like the person loses hand because of the rupture of the radial nerve, the muscles don't work. Those kind of things, like both. It could be motor, it could be sensory. Now there is a central pain related to pathologic functioning of CNS, like cortex, midbrain, medulla, spinal cord. So disease is often the cause, may cause immediate pain. Okay, immediate pain like your thalamic pain. Do you know about thalamic pain? How many of you have heard about thalamic pain? I mean, of course, whoever has passed, definitely yes. But whoever is in third year, maybe they'll be studying about thalamic pain in final year. It's one of the most excruciating pain I can tell you. And this pain is uh, something the person is not able to handle many a times. In a stroke, these kind of pains are there, no doubt about it. So our theory is like, our devices, electro devices won't be working well with the central pain. Okay, keep in the mind. Okay, yes, definitely, yeah. Yes, treatment resistant pain, yes. So the thing is, these won't be working with the central type of neuropathic pain. Means you can't say your patient that I'll be giving you TENS and then it will be very good for your the pain in the thalamus. No, it doesn't happen. Neuropathic pain, it can never work. Okay, but yeah, peripheral type of pain, it will work definitely, no doubt about it. So in coming time, we'll be choosing about our device, no doubt. Let us learn about some more basics. Psychogenic pain. Okay, there is no pain, but still, patient complains of pain. But don't be think that this guy has gone psycho or something. It's not like that. It originates from the non-organic psychological sources. It is frequently associated with the emotional, cognitive, and behavioral responses. Its management is beyond the scope of the devices. When we'll be seeing each other in the physical event, I'll be explaining more about it. The thing is, like, you'll be getting the patient who will tell that, oh no, I can't sit on the wheelchair because my I have a fear of falling, or I'm getting back pain. Okay, and telling a lot about it. After sometimes they say that many times they have the back pain. I have two cases where my colleague has reported me that, like, just talking, just counseling has effect of reducing the back pain, which was not possible for last 10 years with many medicines and electrotherapy. He's also a physiotherapist. Okay, so carcinogenic pain. Next, it is caused by the presence of cancerous pathology anywhere in the body. I'm telling you, practically our devices has not to be used, okay, to treat such type of pain. So active physiotherapy, active electrotherapy, don't use in the pain related to tumor. Okay, ask the doctors before doing this. Okay, now experiencing the somatic pain, how one experience the pain. So there is something called the pain process, okay, where the transduction happens, then peripheral transmission. What happened in transduction? Let us explain one by one. In this phase, your most of the kind of like chemical, mechanical, thermal, these kind of things which affect the nociceptor at site is getting converted into electrical energy, we say. Okay, which generates action potentials that lead to production of nerve impulse, right? So these nerve pulse in the peripheral transmission usually get propagated, okay, from nociceptor to spinal cord. Then of course it goes through the two kind of sensory nerve cells, every one of you know, A delta and C fibers. Former carries faster, okay, I mean the A delta, and the latter carries a slower rate. Okay, so this is what we say the first order neuron. But when it comes to modulation, where the pain get modulate, okay, so diminution, suppression, or amplification of pain, all these are the part of modulation. It happens in this particular stage. So pain modulation reflects action of our own thoughts and emotions. Next is something called central transmission. It encompasses ascending transmission or projection of nociceptive nerve impulses generated by spinal transmitting neurons. That is what we say the T neurons, along with the spinal cord and through ALS and lower brain and cortex areas. Here, T neurons are also of two types, like NS, nociceptive specific, and WDR, wide dynamic range, which constitute the second order neuron. So in anterolateral system, if you see, these impulses are first transmitted from spinal cord to medulla, pons, of course, and the midbrain along the anterior and lateral part of this very said anterolateral system. Then these are transmitted to subcortical areas like limbic system, nucleus raphe magnus, very popular, NRM, pre-aqueductal gray matter means the PAG. Then this system, which is composed of several specific pathways like spinothalamic, spinoreticular, mesencephalic tracts. So this is what the system is made of. So these pathways serve different functions. Okay, so after ALS made their synaptic contact with the subcortical neuron, that is what we say the third order neuron, a new set of impulses originate. These nerve impulses are transmitted to cortical neurons. Okay, this is what we say the fourth order neurons for final pain perception. So perception phase, pain is perceived finally. Okay, but it relates to detection of which kind of nociceptive areas it is. So organic aspect finally become cognitive aspect. So that is what you find. Okay, fine, somebody is poking pin to me. That's how you find at that stage. But these are very fast. The pathway is very, very fast. Most evidence says that somatosensory cortex is more important for spatial and temporal features. That is the location, duration of the pain. But limbic and paralimbic regions are very important for emotional and motivational aspect of pain. So this is how it gets differ. So as soon as we perceive pain, we try to modulate means downwards. That is attempt to suppress by acting on it. Okay, but pain can modulate up or amplify too. It can happen. I'll tell you how it happens. Of course, these all things you can find in the book. Then why did you join my class? You join my class to understand at different phase which work. That is how you will be able to know which device or any device which level you can work upon. I mean to say somebody is poking the pin to me in my palm. I'll be stopping him. Why I'll be stopping him? Because through this 5 phase, my brain come to know, okay, fine, it is a pin or somebody is pinning here. So I'll be trying to stop it. Now I'll be giving you through the pictures you'll come to know. Physiology of pain perception I have taken from NIPC, where the transduction, transmission, modulation, and perception it happens. You can see the injury in the palm, then it goes to peripheral nerve. That is where the C fiber, A beta, A delta fibers are also there, and then it goes to the dorsal horn of the spinal cord. Then it goes to ascending pathways, which is composed of various things we spoke about just now, ALS system, and then it goes to the cortical areas, subcortical areas. That is how you find the pain get modulated. Now you see ascending and descending pathway. I have given ABCD or 1 2 3 4. You can just find out how the descending pathway work, how the ascending pathway work. It is there in your manual also. It will get. Yeah. Now this is what I want you to understand. Yes, targets of pain therapy. So what all things you have, how it targets. This is what you get the benefit when this is what you find today's class. This is not easily seen in many of the books, or it's not easily read by physiotherapists in many of the books in second year. So you see, pain is trauma is here. Okay, so the kind of the site where the trauma happened, where the peripheral nociceptors are there. So you have something to to suppress the signals over here. So what you can do, you can use the lignocaine, the local anesthesia, right? You can use NSAID. You can put that what you say, the Volney kind of a spray or move kind of a spray or a lot of Ayurveda oils, right? That is how you suppress the signals going up to the brain, right? So in peripheral nerves, you inject the local anesthesia, right? Okay, at the end, what do you do here in the spinal cord level? The dorsal horn level. You use the local anesthesia again. You use the opioids. Use the alpha 2 agonist. Okay, then it goes to brain level. What do you use? Again, opioids, alpha 2 agonist. So morphine, that sort of things. Okay, so here you see pharmacotherapy. You have non-opioid analgesic, opioid analgesic, nerve blocks, adjuvant analgesic like neuropathic, musculoskeletal. Electrical stimulation, you can use TENS, you can use PENS. Okay, you can use alternative method like acupuncture or general movement science like physiotherapy, and then of course chiropractic, or you can go for the surgery. Suppose there is a lot of pain in the wrist because of the median nerve get entrapped. Okay, carpal tunnel syndrome. What you can do, if pressure is so high, you can actually go for the surgery, right? You go for the surgery. You go for the surgery only to release the pressure, right? Once you go for the surgery, pressure is released, so pain is perceived less. Now you see here descending pain control, how it happens right from the top. Okay, cingulate cortex and amygdala. Here, emotional states, PAG matter, opioid receptors or projects to raphe nuclei. Then raphe nuclei also the same thing, project down to dorsal horn and spine 5 nucleus. Then serotonin, you know serotonin, stress hormone, everybody knows.
Yes,
Okay,
sir.
yeah, inhibits ascending system like substance P released by the primary afferents. This substance P, many of you who are a student are well aware, because this P substance are studied more because of the 2 marks question in, I don't know, in my university at least it was a 2 marks question, very popular. So P substance, we actually try to remove the P substance, isn't it? That's how we try to learn in the second year. Now you go to the locus locus coeruleus, then there you use the noradrenaline kind of stuff. Yeah, then stress induced analgesia too. Well, now now you see here, this is what I want you to understand at last part of our basic like discussion today. You know, something called the pain sensitization. It could happen peripheral, it could happen central. Once you understand the pain perception or pain, like the process of pain at different level, then you can understand sensitization quite well. If I am having injury at my I can say that at peripheral tissue or maybe the palm, let us take an example. You have inflammatory mediators where the immune cells are there. So this is how, if more and more and more stimulus is there, it will be called peripheral sensitization. Okay, but the same thing when is, it's the afferent, it goes to dorsal root ganglion, then it goes to the spinal cord. Spinal cord is also the part of central nervous system. So happening anything here which is primarily involved the glial cells. The glial cells are very, very important nerve cells. I think most of you know about it. So these glial cells, when it get activated more into this particular pathway, this is what we say the central sensitization. Okay, now let us talk about placebo. How does it work? Okay, one patient came to me and saying that, sir, what you are doing this round treatment, no, it was working a lot for me. Or somebody coming to me and saying that what you were doing, the kind of what we say heat thing, it was working well for me. Otherwise, I don't get much pain, but I feel that I'm having a fear of getting pain. Okay, or I'm getting pain, whatever. So placebo, we say in the science, that is placebo. Okay, placebo is nothing, it is something that the replacement of real treatment with something which actually works almost equal as long as the outcomes are concerned. Okay, here you can go through this placebo part. I have selected from some of the very important book here. It's very, very easy. I mean, the easiest than this placebo experiment I can't do. So normally placebo goes for serotonin dependent hormone secretion, which is something the cortisol. Okay, and then if you talk about context, then non-opioid mediators, then endogenous opioids, which goes to different type of mediators, and then it goes to the preaquitectal gyrus. Okay, matter, and then raphe nucleus. Okay, after that it goes to the inhibitory part of the pain. So there is a lot of things which is involved in the pain process. So now we'll be breaking for exact 3 to 4 minutes of break. Okay, so after that we'll be connecting each other for cryotherapy very soon. So I'm stopping the share for some time, just 5 minutes break. I think it's a 4:56 or 4:55. At 5 we'll be again connected. where your electrotherapy can work well. Uh, just a minute, everybody on mute. I'll just speak to CEO sir. CEO sir, listening? CEO sir?
Yes, sir.
Okay.
Yes, sir.
Yeah, please make me co-host. I will share the screen.
Yes, sir.
Yeah, thank you so much. So now let us see which all kind of equipments one use when it comes to opening a new physiotherapy clinic. Where to use, how to use. I know you must be knowing a lot about cryotherapy, but today you will be listening and learning a lot things which will add up your own existing knowledge. It may change your existing knowledge a bit, but overall, I can promise you that it will change your approach. Your approach. How do you use the cryotherapy? So cryotherapy. Every one of us know the use of ice. Well, uh, yeah. So definition and history. Let us talk about cryotherapy. It has been derived from the Greek word cryos. Every one of you know, which means cold. Okay. So cryotherapy is basically the use of ice or use of cryo agents to lower soft tissue temperature for therapeutic purpose. Okay. Cryotherapy dates back to ancient Greeks and Romans who used snow and ice to treat different kind of health problems. Okay. And then what happened later phase in 1950s, I can tell you, in mid 1950s, clinical use of various kind of cryo agents in different kind of forms, which emerged under the leadership of physical therapists and athletic trainers across the world, especially in the western part of the world. Okay, so treatment of various acute and subacute soft tissues injury, it became possible with the help of cryotherapy, cryo agents. So after 1960, formal acceptance of cryotherapy by main health streams showed benefits in military. Okay, because it was accepted by many of them from the military zone. I don't want to get into the deep history of that, but still that is true. And then later it became an integral part of physical and sports medicine. So those who are in the sports medicine and musculoskeletal medicine, they know much more use of this ice. Okay, so for them today I'll be giving one bonus or bonanza kind of stuff at last of the cryotherapy, but let us learn how do we use it. So this is how the historical view of this. So common cryo agents, how do you use the common agents? Okay, so you have many things in the market or in your hospital, but let me tell you, every cryo agents has different feature because it doesn't give you the same effect all the time, because the temperature variation matters. Okay, so gel pack. Okay, gel pack very commonly nowadays. Earlier it wasn't so common. Okay, it's nothing. It's a commercial mixture of water and antifreeze that forms a kind of gel which is semi-solid mixture and enclosed in a flexible vinyl cover. Okay, so here the temperature you could expect somewhere between -5 to 0 degrees C. Now cubed ice bag. Cubed ice bag in commercial waterproof bag it comes. It is temperature between 0 to 10 degrees C. Okay, you would have seen this. Even crushed ice bag that you can make it by yourself. Okay, but it is available in many countries in commercial waterproof bag where the temperature again from 0 to 10 degrees C. Now what wetted ice bag? You would have you can again make it. Okay, wetted commercial waterproof bag it comes in market also. Here also between 0 and 10 degrees C, normal temperature range remains. Then ice cup. Take a cup, freeze the water. Okay, and the cup should be the kind of plastic or maybe the styrofoam, very popular cup, white color, that you can freeze the water and you can use at different areas of the patient. Okay, then ice-sleeve. Ice-sleeve is something frozen gel mounted on a plastic handle or wooden stick. Say for example, I'm using this okay, I'm using this. Okay, in this only I'll freeze the ice and then I'll be using as a water cup. as a as a cup. Then it comes to vapor coolant spray. I want you to learn about it because vapor coolant spray is kind of coolant liquid contained in a pressurized canister and activated and manually by a valve. I'm not going to talk about anybody by the name more, but very popularly the move. You can see the rally spray, you can see a lot more kind of spray. There are some sports medicine we are using at on field. We are using that anti what we say anti-inflammatory, I mean the painkiller spray. We are using the this all are vapor coolant. Okay, it works in a different way. We'll talk about it. Then it comes the very nice, I can tell the particular unit whoever is working in multi-specialty hospital, they would have seen this controlled continuous cold unit with compression. Okay, so unit typically made of the cubed ice water filled in a filled cooler and a pad, generally cuff or sleeve wrapped around the treated area. Say for example my wrist is into problem, they'll be wrapping around it. And now the whole overall attracting hose system linking cooler to pad. Okay, so continuous flow of cold water. Say for example this is how the pipe is. Okay, so from the pipe it will be like kind of pipe it is. So pipe is flowing, like from down to from up to down. That is with use of the gravity you can make it hang, or you can have a small motor which is supplying that. Okay, which is supplying the pressure as well as it is supplying the water, the cold water also. So this pressure cuff you can use in the treated segment. Suppose my wrist is swollen, so you actually have something you can just wrap it around, and then you can increase the pressure just like a sphygmomanometer, and then you have a flow of the water too, cold water in fact. So what are the biophysical principles you apply for the cold? When ice is applied to the skin, heat is conducted from skin to the ice in order to melt it. This is what the whole idea behind it. To change its state, ice requires considerable amount of energy that we call as a latent heat of fusion. Look, heat is a concept of nowadays. Of course, in the school also we have learned about it. But how does it work? It's something like a change of state of matter. Okay, so that require energy. That's the reason in summer days when say for example I'm in Rajasthan in month of May, so I'm sweating, isn't it? So whenever there is a small breeze, I mean the breeze start coming, we feel cool. Why? Because the sweating part which is getting dried, right? So from liquid to gas it's happening. So the energy for conversion from one state to another is getting it getting drawn from my body. That's how we feel cool. So evaporation causes cooling. Okay, so this is how the state of matter gets changed, and then this latent heat which is inside the subject which is used, this is what we have the concept of cryotherapy too. So a specific amount of energy is required to change the solid state to liquid or liquid to gas. That's what we say, latent heat. Temperature changes in tissues will depend upon the rate and amount of heat energy removed. Okay, the colder the application, greater the heat loss from the tissues. Understood? Then amount of loss of energy depends upon the length of time of application of cold too. You can't have a look. Suppose it's a kind of spasticity. I'm having a left hand spasticity, so you can't keep the whole ice pack on me. Can you? You can't, right? Then what you can do? I'm not testing every one of you. I'm just asking them. Don't take it another way. So what can you do? Suppose my left hand is spastic. I'm a patient. I came to your clinic. So with the ice, if your senior physio or your principal or anybody says you do something, what are you going to do with that? With ice, what are you going to do? Of course, you can't keep the whole ice bag on my hand, right? You will be doing the ice stroke massage. Isn't it true? You'll be doing the ice stroke massage. Let me check. Via pressure. Yes, Sapna, you're okay, but I came with a spastic hand, so I won't be able to get more and more ice effect. Again, this story of spasticity which works through the Golgi tendons and all those things. The stress receptors will get activated, and myself can get more spastic, right? So I'll be taking ice cubes and I'll be rubbing it here like this. Okay, stroke massage. Okay, but if I come with uh, with with ankle injury or ankle twisting, or say for example some of the elbow injury or shoulder injury which is quite acute in nature, then definitely you'll be applying for 5 minutes, 10 minutes, 15 minutes, 20 minutes, right? So this is what I was saying. Yeah, of course. In that case, Sapna, whatever she said, it is correct. I mean, you'll be able to apply with the pressure. Yeah, well, continue. That's fine. So, according to the situation, you apply that. Okay. According to the contraindication, you apply, but according to the condition, you apply. First, learn condition, then indication. Indication, condition, and then of course the contraindication. So amount of loss of energy depends upon the length of time of application of cold too, and the larger the area, more heat energy loss also. So it depends. Suppose you are using an ice cup. So cup will have a diameter of, say, for example, 4 inch. You can't expect the more power loss from your body. I mean, the more thermal energy getting exchanged compared to an ice gel bag, which is quite larger in the size, and of course it can have same effect across the more area, right? So now let us talk about how do we apply. I mean, of course none of us generally do this. So okay, fine. Before applying this, before bio application, let us learn the biophysics. Again, the circulatory response. Okay, so circulatory response, and then you will have metabolic rate, motor system, neural response. These are responses I have detailed, but the master of everything is in this photograph. I mean, is this flow. What I would suggest you, these all kind of thing, you can, because I've taken from some of the lecture notes, some of the books, some of them I made through myself also, a lot of things in this. What you can do, you can actually make a poster and keep it in your clinic. Okay, you can actually stick in your clinic, no problem. There's no copyright concern from my side. Don't worry. This much authority I can give you. Okay. What you can do, you can just keep in the clinic. So what happened? These all things show how serious you are for your patients. Okay. These all things. Okay. Forget about patient part. That's something we'll not talk about much today. What I'm saying you, this all shows you can actually revise yourself. Okay. You can revise yourself. You can revise any number of time, any point of time. Okay. And I would say that okay, let us talk about this chart. Cryotherapy, of course, thermal energy exchange, right? So first we learned about biophysics in this. So heat extraction, right? That's what we were calling about. I mean, talking about. So heat extraction causing cooling here. This cooling, if it is a minimizing secondary tissue damage, how it is minimizing? I have given in a small this one. You see, vasoconstriction, decreased blood flow, decreased metabolism. So those who are student and can get the question like this is how the chart you should explain in the paper. Okay, this is how you should explain the paper. My okay, at this point of time I'll tell you that my academy where I'm full-time worker, my rehab academy, we are coming up with the whole idea of giving coaching to the students also, not just passed out. Even the students of third year, second year, first year, and final year, of course, we are going to give theory as well as the practical classes. Wherever they feel difficulty, they can actually join. So right from the month of December, I feel that it will start. So those who are a student can any time can join at very reasonable fee to our academy. So this is where we will be learning more about student things. So here you see decrease edema. So reducing the free proteins, that is how it decrease the edema, right? Okay, well, decrease pain and spasm. Thermoreceptor activation, decreasing nerve conduction velocity, counter irritation. That is how it will decrease the pain as well as the spasm. I'm talking about spasm, not spasticity. Now we'll be talking about decreased spasticity. That's the reason I've given in the yellowish, right? Nerve part. So decrease muscle spindle and Golgi tendon activity, decrease gamma motor activity. Okay, these are all the two reasons where it actually works on spasticity. So dear all participants, whoever is working in hospital or passed out, that's fine. But who all are the students can learn a lot about it and then can have easily memory for writing answers in the exams too. So this is how you can, and then uses of cryotherapy, of course, or reducing pain, reducing spasticity, reducing muscle spasm, reducing swelling, promote repair of damaged tissue, provide excitatory stimulus to inhibit muscles, used in strength training, right? Next, indications, you have a lot more indication, also, I have also listed, please go through in your manual. Then contraindication, very important. I'll explain this. Why? Because you can't use the cryotherapy in Raynaud phenomena kind of stuff, or Raynaud disease, or impaired circulation. You can't use it. You can't use it. Okay, peripheral vascular diseases, you can't use it. Say for example, Burger disease, you can't use it. Okay, hypersensitivity to cold, you can't use it. There are many people who are hypersensitive to cold. You can't use it. Skin anesthesia, please don't use it. If somebody is having a problem with the sensation, please don't use it. Okay, there's something called ice burn. It can happen. Okay, open wounds or skin conditions. Okay, in whirlpools or contrast bath, don't use it. Infections, never ever use it. Okay, don't try to use these all places. Dangers are frostbite, cold induced neuropathy. Okay, this is how you are killing the cells, killing the receptors, even whichever are there in normal condition. This is how you should not use who has a compromised sensory integration. Okay, clinical application techniques. I want you to focus more and more about it. Okay, we will be talking about steps first, then we'll be talking about the process. So step is what you should do. This also you can keep in your kind of, not kind of poster, but in your clinic kind of what we say, the kind of modus operandi. Okay, modus operandi, you can keep it like that. So steps of cryo applications, how it goes. Checks for contraindication. First thing you check for the contraindication. Okay, seeing a diabetic, like a diabetic foot person who came to my clinic and then has a ankle twisting, I want to apply ice. Then I, when I'm making the goals, sorry, the assessment, when I'm taking the assessment, that time he said me, yes, I'm having diabetic problem, I'm having diabetic foot, I was diagnosed about 2 years before. I'm just thinking, okay, with the ice I can treat this patient. But no, sorry, you're wrong. Right now here not allowed to use ice. If he has a compromised, already diagnosed with diabetic foot, please don't use that. Even though somebody says that he's diabetic, please check sensitivity. You are a wonderful person to check sensitivity. Okay, so don't use cryotherapy for sensory compromised person. So the first step I have kept is check for the contraindications. Then suppose he is a diabetic, but he has no problem with his sensation. As you have made assessed, okay, you have assessed, you have made assessment. Now consider the risk. For normal person, if you are keeping for 15 minutes, say for example, in case of ankle issues, I'm taking ankle issues because very common in the sports. Okay, uh, so for this kind of person, when you are keeping the eyes, be watchful. See the skin changes every 5 minutes. This is what I said. Consider the risk. It's not always that all are contraindication. This is how you would have studied in your book: absolute contraindication, relative contraindication. So relative contraindication, when it comes, of course, you have to consider the risk. Okay. Then third thing is, once you have considered the risk, then go for the position and instruct the patients. Patient is having, say for example, 6-month history of prostate surgery. Okay. So now, what is the position, best position you will be attending? Good. So positioning the patient, and then you start. So before starting, I told you check for contraindication, learn the risk. After that, you go for the positioning, which is the most comfortable for the patient. Then you prepare the treatment areas. So we have very commonly said the treatment tray and the patient tray, right? Prepare that. Then you go for the selecting appropriate cryo agent. In my clinic, if I'm having all 8, I'll be choosing only one, right? I can't be choosing 2, 3, 4, 5, 6, 7, 8. All 8s I can't choose for a single person for a single time, right? So I'll be choosing whichever is the most comfortable for him. Okay, so now this is where you'll be applying your idea. I mean to say, suppose I told you in initial part of my cryotherapy lecture, I told you something is there which is actually having a 0 to 10 degrees C. Something is there which is -5 to 0, right? For diabetic person, automatically your choose will be 0 to 10 degree, isn't it? Because you don't want to compromise with more and more sensory issues. Everybody agrees? Look, if you are not able to speak just by unmuting yourself, no issues. What you can do, you can just give the reaction. Okay, so giving your reaction will make me more interactive. So even though chat, if you are not able to do, you just go ahead with the reaction, like thumbs up or something like that, so that I'll be knowing that you are online and then you are doing it. So this is how I wanted to convey you. So like the sixth stage, very important. I want you to know about it. I have written, I have typed it: determine and measure doses. Sorry, disease it became doses. Okay, how do you determine and measure the dose? Okay, here you check the temperature of the agent. Okay, say for example, agent is like the cryo agent is at temperature of 10 degrees C, right? And then now you check the temperature of surface, skin, okay, skin. Then wrap up and secure the cryo agent. Okay, how do you have to apply? Apply the treatment, and after that measure the thermal skin cooling, means temperature B minus A, means temperature before application, temperature after application. You find out what is the degree of reduction. Okay, conduct post-treatment procedure like examine erythema level, very important. Keep unit back, wash your hands, ensure post-treatment equipment maintenance. Say for example, if you are using gel, please wash properly with the water, running water, if possible with some soap water, then you again keep in the refrigerator. Don't keep as it is. Okay, if it is a styrofoam cup which you used for the cup kind of treatment, please throw it off. Don't use again. Okay, if you have used a plastic cup for the same purpose, throw it off. Don't use again. Okay, so this is how you should go ahead about the steps I was talking about. Then continuing this, I can tell you clinical application could be done through different cryoagents in order to get desired results. Okay, how do you apply the different agents like ice towel, ice pack, immersion, ice cube massage, cold compression unit, ice spray, and contrast bath, of course. Okay, so time of application, generally therapeutic, I can say the cryotherapeutic sequence occurs within 5 to 20 minutes. To get better analgesic effect, minimum 15 minutes are necessary. So you got the point. If somebody coming with the pain, go for minimum 15 minutes. Analgesic effect won't come before that. Okay, it's not that you have kept 5 minutes and you can expect something else. You can't. So this is how you should classify that. And then now we'll be talking the very interesting phase in this cryotherapy called cryo in sports. Okay, it's very, very useful in acute phase. Of course, every one of you know about it. So now let us talk about it. And just one sec, I'll see. I hope everybody is seeing that. And yeah, so in acute phase of the injury, what happened? Either in the field or during the gymming or exercise session, or maybe the training session of the sportsman, cryotherapy in the form of either direct application or cold packs are widely used everywhere in the world. So cryotherapy is given for at least 72 hours from the injury, but provides best result within 2 days or 48 hours of injury or acute conditions. So when it comes to sports, it's not just once in a day, it's something the 4 times, 5 times in a day. Okay, gap of 3 to 4 hours or 5 hours, you can go ahead, but you must. So those in musculoskeletal science can understand this very well. They have been working with the people, they have been working with the athletes. Okay, now let us talk about rehabilitative phase. Okay, rehabilitative phase, I have taken an example of, say for example, ankle sprain. Okay, well, so here the rehabilitative phase will go like 2 types. One will be the cryokinetics, another will be the cryo stretch. Try to learn very patiently. Cryokinetics. What is cryokinetics? Have you heard of? Okay, it is combination of cold application with active exercise, nothing else. Cryokinetics are important as cold decreases pain, which facilitates active exercise. Exercise reduces swelling dramatically and promotes healing, which help in returning to normal function. Only disadvantage is with the cryokinetics is what? It increases pain during initially 4 to 5 sessions or maybe 1 or 2 sessions. So initially for a day, it could be painful, but don't deter. Continue. Then indications: sprain, ankle sprain, fingers, strength training, anywhere you can use it. Contraindication, again the pain sensitivity, the cold hypersensitivity, severe erythema, or pain creating activity or exercises, right? Any kind of exercise which increases the pain, don't do that. Then precautions, pain as a guideline. Of course, pain will increase initially. Don't allow patients to limp. Go for the normal activities. Pain may go higher after 4 to 8 hours of treatment. That happens with most of the cases, but don't reduce it. That is how the common theory is. Now the principles. Okay, all exercises should be active. Try to learn the principle very properly. And the exercises must be graded. It must begin with the range of motion exercises. First complete the range of motion, then progress through the increasing level of difficulty, and finally sport level of activity. Well, the non-weight bearing range of motion. Say for example, I told you about the ankle sprain. So you can go for the plantar flexion, dorsiflexion, inversion, eversion, Then circumduction. Well, weight bearing range of motion. Stand up, shift weight from foot to foot, or gradual increase of weight on injured foot. Okay, so the balance system, what I was saying. So these all are the principles you need to follow. Then cryo stretch. Cryo stretch are widely used in sports injury. Again, most of the strains and contusion result in the muscle spasm or tightness. Many mild muscle pulls are actually muscle in spasm rather than the torn muscle fibers. Okay, it's mostly the muscle fiber spasm what we get confused with the tear of muscle fibers, maybe the grade 2 or grade 3 we say, but mostly it is a spasm part, right? So what is the goal here? Rehabilitation goals: promote torn tissue healing, controlling the pain, again reset central control through aggressive progressive reorientation of full function, then control neural inhibition, of course reduction of spasm, uh, promoting like the next phase of rehabilitation, of course developing the muscle strength also. Then application parameters, learn here very properly. We have a 3 sets: numb, with, ice, then activity, that consists of 265 seconds bout of exercise with 20 seconds rest in between. Don't get confused, I'll do maths later. First you learn it. 65 seconds bout, what do we do? Stretch muscles to limit and hold for 20 seconds. Okay, 3 static exercise stretches interspersed with a maximum isometric contraction, means hold, relax, hold, relax, hold, relax. Example of exercise bout, I'll tell you how it is. 20-second static stretch, say for example my wrist, 20 seconds of static stretch, 5 seconds of isometric contraction, okay, then 10 seconds of static stretch, 5 seconds of isometric contraction, then 10 seconds of static stretch, 5 seconds of isometric contraction, then at last 10 seconds of static stretch. This is how 65 seconds of bout goes away. Okay, now let us do some math of application. How do you do that? So numb muscles for maximum 15 to 20 minutes, then go for 65 second stretch contraction, then 20-second rest, repeat 65-second stretch contraction, again renumb because the temperature would have increased, so renumb, again go for 2 more stretching bouts of 20-second rest, again renumb, then go for 2 more stretching bouts of with the 20-second rest. Okay, so once you learn about the math of application, you are the master. Okay, this is how the cryo kinetics and cryo stretch are applied. I want you to apply with your patients, considering the age, activity, and lifestyle factor, and you see the benefit of this. It definitely benefits very well. So combine cryostretch and cryokinetics, of course you can do it. So begin and end with stretches. Remember that. Begin cryokinetic exercises with manually resisted muscle contractions, 6 to 10 level. Okay, 6 to 10 number of repetitions, in fact, through a full range of motion, of course, and use dapper technique. I'll tell you what it is later for further progression. Then progress through all phases of rehabilitation during using progressive functional activities. So this is how you should go ahead with this. So now we'll be talking about vapor coolant application method. I told you earlier we'll be talking about this. Okay, so hold the vapor coolant upright about 30 centimeters. Say for example, I am having a vapor coolant I'm doing. I'll be keeping the vapor coolant at 30 30 centimeter distance. Okay, then from the skin and angle that spray hit at right angle to the part we want. Apply parallel sprays over trigger point and along the related tight muscles. Repeat spray applications for 3 to 5 times over the painful area, followed immediately passive muscle stretching exercises. Important to remember is stretch is therapeutic action, but cold is distraction. Always remember, stretch is therapeutic action. These all are the roots I want you to learn. And cold is the distraction. Cold we are giving just to distract it. Well, duration, each cold application of 30 to 90 seconds, whereas passive stretching exercises may range between 1 and 2 minutes. Okay, number of application will vary according to the acuity of the condition, of course, how acute it is, and severity of condition under the treatment. So today onward, I'm sure that whenever you are applying the spray, approach will be changed. Okay, so I'm summarizing it. Take a vapor coolant spray, be at distance of 30 centimeters from the skin, and hit it at right angle. That's how the nozzle should be. And after that, you go for the application of 3 to 5 times. After that, you go for the passive stretch of the muscle. Passive stretch of the muscle. Okay, hold for say for example 1 to 2 minutes. Okay, again here, of course, you are applying the cold. Okay, so 30 to 90 seconds of cold application, then passive stretches for 1 to 2 minutes. This is how your approach will change. Okay, stretch is therapeutic action, cold is distraction. Good. Then this is how we'll be finished. We have finished the cryotherapy. We are coming on the thermotherapy. Thermotherapy, the use of therapeutic heat is in the treatment of various conditions has been around for thousands of years. You see, anybody getting neck pain, okay, fine, come, we'll give you the hot pack. Simple, very simple. Warmth is associated with the tranquility and relaxation. You know, it's a human behavior. It is used to treat muscle pain since centuries together. Okay, several studies have examined that the frequency of thermal agents used as an intervention in physical therapy. These studies from Australia, Canada, and England indicated that percentage daily use of therapeutic heating agents such as hot packs or maybe the wax therapy or hot water bag, these all are ranging from 36.5% to 95% in various practice settings, not just physiotherapy clinic, even in the sport medicine, even in the relaxation center, or even in this. There are many more practice stages, even in the Ayurveda. Okay, so hot plays very important role. So biophysical aspect, how do we choose it? Many sequelae can occur as a result of increasing the temperature of the body rises. The occurrence of physiological changes, in fact, are dependent upon several factors. Okay, extent of temperature, increase, rate at which the energy is being added to the tissue, volume of tissue exposed. Okay, volume of the tissue exposed, and composition of absorbing tissue, capacity of the tissue to dissipate heat. If it is a fat, you can't expect the same thing, right? So this is how it goes. And next, I have made a beautiful chart here too. Yeah, this is the normal chart where you actually come to know what is the degree C and what we are using. Okay, we have just learned about cryotherapy a lot, right? So let's talk about this. So say for example, it's a 5 degree C or 0 degree C. It's a behavior regulation, right? So may not be able to perceived by everybody very properly. Then 10 degrees C very cold, we say. Okay, in general, I have made this in general. It may not be true for everybody, or it may be your approximate value. Of course, it's approximate value. So 10 degrees C very cold, I say it's very cold. 15 degrees C cold. 20 degrees C region of thermal environmental comfort, cool. 20 degrees C. 25 degrees C neutral, Bangalore's temperature. Okay, 30 degrees C warm. 35 degrees C normal body temperature, what we say hot. 40 degrees C, 40 degrees C, here it is resting body temperature, it's hot, okay. 45 degrees C very hot. 50 degrees C tissue damage, burning pain. Okay, that is how the grade 1 burn we subject to. Okay, so this chart you just go through. After that, I have given the biophysical effects. So most of the effects I have chosen here between 104 to 113 Fahrenheit. That is about 38 or 38 to 50 degrees C. Sorry, 39 to 50 degrees C. Okay, so on metabolic reactions, on vascular effects, these all I have made a very beautiful diagram. You can see heat, how it activates the prostaglandins, histamine, kallikrein. That's how it goes for vasodilation. Okay, small arteries and arterioles get vasodilated. Okay, increasing the vascular permeabilities by bradykinin. That is what is happen on the vascular things. But before that, I will explain bit more here because it is important for you. On metabolic reactions, like metabolic reactions to heat include the increased cell activity and metabolic rate 2 to 3 fold for every 10 degrees C rise in temperature. Okay, every 10 degrees C rise in the temperature. So okay, so an increase in chemical reaction rate can also have positive effects of positive effects, I can tell you, on in general physiological function, and then oxygen uptake by tissue will increase. Theoretically, more nutrients will be available to promote tissue healing. But one more thing I'll tell you, more nutrients will be available, but more waste also will be created, right? So on vascular effects, increasing tissue temperature is usually associated with the vasodilation and thus with increase in the blood flow to the particular area. Okay, so in the response in the same direction again doesn't mean the magnitude also will be the same. Okay, we'll be talking more about it. Now this is something I have given you for the thinking. I mean, you have learned a lot of electrotherapy past many years, you have used it. Can you tell me one thing? A local spinal cord reflex is elicited, that's very sure, through heat activated cutaneous afferent stimulation. Suppose somebody has, I went to the physio clinic, or I met my physiotherapist who actually kept a hot pack on my shoulder because I am having some shoulder pain. Okay, it's a story of, don't think that why he used a hot pack, just think he has used, so what will happen now? So now what I'm saying you, this is to, it's a reasoning question, because I believe in the analytical teaching rather than textbook teaching. So this is how. See, he has kept a hot pack over here, hot water bag. So hot water bag will definitely heat me in the local area, right? That's how the effect is. But why can't it have a reflex on the spinal cord? It can result in a decrease in ganglionic sympathetic adrenergic nerve ability to smooth muscles of the blood vessels also. There is a limit of blood vessels, right? There is a limit of elasticity of the blood vessels also, right? After a certain degree it won't dilate, but it will dilate, it will definitely dilate. So if the moment it start getting dilated, the vasodilatory effects of this reflex are not limited to the area heated, then dilation effect will go even later, right? So this is what for your thinking. Okay, so there will be a consensual response in areas remote from the application. Now my wrist is also getting not heated, wrist is getting, wrist vessels are getting dilated, so more blood flow, right? Everybody agrees? At least thumbs up. If you don't agree, we'll talk about it again. What I'm saying is just for your
Yes,
thinking,
sir.
right? Yeah, it's just for your thinking. If somebody is applying the hot water bag here, it's not something that it will heat up just smooth muscles over, sorry, the musculoskeletal part over here. No, what I'm saying you, it will dilate the blood vessels across, even in the remote areas. So now, using this tip, you can use the hot water bag in the burger disease. I mean, any sort of diabetic foot people also. I mean to say, you want to heat up, uh, leg, then you can keep over the knee, and then you can think that of course blood flow will be more there, right? But practically it is not taken. I mean, the clinically it is not practiced because it's not rationally, but it is possible, right? Cutaneous blood flow can be increased by hitting the lower back. Yeah, it's possible. That is how you get relaxation. Thank you, Mayuri, for accepting. This can happen, right? So this is what for your thinking it is. So I'm telling you, putting the heat application over the skin for your patient, it just won't vasodilate. It will have effect on the spinal cord. Definitely it will have effect. Okay, so you can use this method also. Okay, after many research, it is proved that modalities plus exercise always give better results. So I always say people go for the physical like exercise therapy along with the hot water or hot packs. So they found doing simple exercises like pressing a small rubber ball with hand increases better blood flow than giving just hot packs to it. It means hitting skin does not necessarily increase the same kind of blood flow beneath the skin, right? Because as it will be going through the skin, the effect of heat will reduce, isn't it? It will reduce. Now, neuromuscular effect. Okay, neuromuscular effect is like heat is therapeutically to provide analgesia, you know, every this thing very well, and to assist in resolution of the pain and muscle guarding spasms. Raising subcutaneous temperature using a variety of heating modalities has been demonstrated to alter sensory nerve conduction velocity. Most pronounced changes appear when it start first 2 degrees C. Then heating over an area peripheral nerve can elevate the pain threshold. Okay, according to the research, fluidotherapy. I'll be talking about what is fluidotherapy, but fluidotherapy decreased sensory nerve latency of superficial radial nerve after 20 minutes of application. So DOMS, delayed onset of muscle soreness. It can decrease after 30 minutes of dry heat application compared to the cold. So for DOMS, I always say people, don't do anything, don't stretch anything, just go for initial 30 minutes of dry heating. Dry heating, again, mark my word, I'm not saying the dry heating, sorry, the moist heating. I'm saying the dry heating. There is a difference. There is a marked difference. Okay. So yeah, this is the beautiful chart again for your own refer. It will be there in your manual. Please go through that, and anytime you can ask any questions on this. And
So you said for domes using rather than, I mean, comparatively, dry heating works well, but in the domes is due to the microtrauma which is happening. Usually they go with the cryotherapy to cessate the microtrauma, but we go with the dry heating, it will increase the circulation. Won't it be aggravating the things in acute,
yeah,
like domes is
of
the
course.
acute one which is happening?
No, I'm talking about. No, I'm talking
Domes,
about.
like suppose if I'm doing a workout today and domes which is going to settle tomorrow, right? Within 24 hours.
In general.
Yeah. So in this case,
Okay, let me
application
clear
of
it. I
cold.
mean, of course, I wanted to clear later, but let me clear it since we have raised this question. Suppose I'm doing exercise, okay? I'm doing a cross trainer, say for example, okay? Doing cross trainer, what happened? My back got bit spasm, okay? Just understand that. Or it is a kind of muscle strain it got. What are you going to use? Or muscle got sore, say for example, in general. What are you going to use, ice or heat?
Ice.
100%, you're correct. I appreciate that. But I did my 3 days regularly running on the cross trainer. Now I'm getting a soreness. I'm not able to get up in the morning. Like back looks stiff, especially the lower back and right hip side. It looks stiff. Okay. In this case, will you use ice after 2 days?
No.
You can use, of course, you can use some cupping therapy, or you can use some ice, you can do some exercise, you can do. But what I said, you did not mark the word. I said here the hot works, the dry heat works better than the
Better.
cold. Okay, it works
Yes, sir.
better than the cold. That's what I told you. It has been evidence, it has been found. You can use cupping, you can use your icing, you can go for the reduction of soreness or spasm, whatever. But delayed onset of muscle soreness, whichever has been delayed late, I mean, sorry, the which has been delayed in getting set, the soreness, muscle soreness. Here, if you use the dry heat, that works better. Reason behind, I'll tell you, the soreness where you have a ordinary circulation of the blood, okay, ordinary circulation of the blood. Initially it was very good to reduce the pain because the pain was more factor, isn't it true? Initially when the person got pain, pain was the prime things to reduce, true or not?
True.
But after 48 hours or 72 hours, the thing is now with pain there is some stiffness also, or maybe you can say there is a slowness, not able to bear the weight the muscle is supposed to bear in general. Okay, in that case, what are you going to do? You are putting the dry heat, okay, to have better transfer of what we say the extraction of the heat from the the agent to the body, so that better blood circulation goes, muscle get more nourishment. Is it, do you agree here?
Yes, sir.
Yeah. Now I'll be making you more clear about it. You see, suppose there is a stiffness due to the SI joint dysfunction. Okay, I mean SI joint, I'm having SI joint a problem earlier, and then I did a lot of gymming or a lot of sport activity, then I got SI joint problem also along with this. Okay, so after 3 days, what do you think? Dry heat will be better or not? Okay, okay, I'll make
For
it more simply.
stiffness, yes, sir. Heat is better.
Better, right? Heat is
Whenever
better.
there
Now
is
you came to the
stiffness,
heat, right?
yes, there is.
Now in this heat part, I will tell you one more thing. Initially, what I'm going to use as a clinician after 3 days, I'll be using the dry heat to reduce the muscle soreness, make the muscle more active, and then of course the pain, then you will be finding the trigger point is somewhere near the SI joint. True or not? Then you go for the weight heat also to reduce the stiffness part. Isn't it true? Then you can go for the stretches. If I'm wrong, just let me know.
So, but how are we connecting this to DOMS when there is a micro trauma? We would not want to increase the blood circulation over there. We would want to at least create some kind of numbness and cessate the activity, right? So, like the question was something else.
This is what I'm saying
Why
is,
would we go for dry heat when we want to actually kind of anesthetize that kind of pain? DOMS is it's actually an unpleasant sensation, so we would want to cessate the sensation basically. So that's exactly why we go for icing, right? So like
and that
when you say
unpleasant
dry
sense
heat,
is,
we can think of something like IRR as well. So IRR, as we have studied in electrotherapy, we can use it on open wounds also. That is essential for healing. But
dry
how
heat
do
is
you?
not always IRR. Okay, IRR is a type of
Okay.
dry heat. Most
Yes.
of the dry heat I consider is, say for example, electrical hot bag. Okay, say for example, electrical hot bag. Okay, which is having a large amount of area to be concentrated at equal temperature distribution. Okay, now what you actually termed as a unpleasant sensation. Okay, that unpleasant sensation is my question to your question is, will be more in first 24 hours or will be the same intensity for another 48 hours, like that? If it is a first
It's
48,
delayed. It takes time and sets in.
yeah, sets in, and then it remains at the average intensity, isn't it? Isn't it?
Yes.
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 So I'm saying you, in that case, I did not straight away rejected that we can't use ice. You can see my statement. Just I'll go back. I did not reject that you can't use ice. Okay, I have given here it decrease after 30 minutes of dry application, dry heat application compared to cold. Okay, so in the evidence we have found it. Suppose somebody coming to me with the DOMS, I'll be using the dry heat. Fairly speaking, I'll be using the dry heat or I'll be using the sine current. Okay, reason behind, evidence-based practice says that more you apply heat, okay, more and more you apply heat, larger amount of time, that will work better than the compared to the cold. So I have not rejected the cold part because I know cold has a prime role in ice therapy. I mean, the cryotherapy has a prime role in decreasing the pain, cessation of the pain. But when it comes to the DOMS, yes, we have some evidence which is saying that 30 minutes of dry heat application is better in effect than cold. So
So to
cold is
be
not rejected.
precise,
So if you're using,
when do we go for cold and when do we go for the dry heat? Coming to this specific condition, DOMS, sir.
okay, so DOMS, as you, okay, fine. Then we'll go to the even more basic, like how do we consider the DOMS, like creating? I mean, how it sets in general. How do you think it sets in?
It's much because of the eccentric exercises. When
Ah,
we have not
yes,
performed enough of
eccentric exercises,
warm
and
up,
then where
eccentric
we,
exercises.
of course, eccentric exercises where we don't let our gravity to control our movements very well, right? Right, isn't
Right, sir.
it? Yeah. So it
Yes.
normally starts a day, maybe mostly a day or two after the activity. That is how it is happening, right? Suppose I'm doing the cross trainer, I may not get when I'm there in the gym or I'm there on the sports ground. Maybe after my training session, after 8 hours, 10 hours a day, I may get kind of pain. Isn't it true?
Correct. So that's why it is delayed.
Yes.
Right.
So when it is a delayed, okay, suppose I started getting initially within 2 hours or 3 hours or within 1 hour in the sports ground only, that we say acute muscle soreness, right?
Yes,
So
sir.
those
Yes,
muscle
sir.
soreness are well responded with the ice. That even I agree, you agree, every one of us agree,
Totally, sir.
right?
Totally.
There is no question. Yes, there is no question of application of heat because heat will create problem here, right? But when it is a DOMS, what I'm saying you, apart from the ice, if you are using the heat for dry heat for 30 minutes, that has better this one, because in that case it has already set in. So it here not just pain is a problem, Here the problem is the overall muscle activity. Okay, so cessation of pain is not the prime function here, not the prime goal here. In fact, here overall the muscle which has having, I can say you, the lot more lactic acid has been formed, which was making the muscular, I mean the skeletal muscle tired. Now our idea is to have more blood flow to remove those parts. You got my point?
Yes, sir. Clear.
Because with the eyes, yeah, I understand your point, because you're focusing on the goal of pain. So here, when it is a dome,
So you
it is
mean
not
to
just
say
pain.
initially after the workouts we do, we go with the cryo, and once the onset is happening, once the domes is
A day or two
happening the
later.
next day,
Yeah.
or the next
Two
day.
later.
So
Yeah.
we'll continue
Yes.
with the dry heat therapy.
At least my
Which
protocol
is,
continues
I
with
mean,
this.
it's the reason is it's not only the pain which is hindering the movement as well.
Exactly.
Or stiffness.
Now what happened, Ashwini, right? I mean, forgot my name.
Yes, sir.
Your name.
Ashwini.
Ashwini. Okay. Yeah, fine. Sorry. What happened here? I told you what is our goal. When it is acute, the pain is the prime function. I mean, pain is the prime focus. But when it is a chronic part, pain is not only the focus. Now it is a dull, aching pain, which is actually hindering my activity also. Okay. So we want more and more blood flow to remove the lactic acid, which has been formed over the period of hours. Got my point? So generally after a day or two it sets in. Okay, is it okay? Everyone is
Sir,
fine
I'm
with this?
so sorry to interrupt. So whatever you told is correct. For healing, we use the dry heat. Totally understandable. But you also mentioned something about the lactic acid, wherein it is, I mean, it's a substance where it can be flushed out only with consumption of water, right? Because it's only residual or a resultant substance what comes after this anaerobic cycles of energy system. How does dry heat have an application of that? I mean, lactic
Okay,
acid.
hypothetically, let me tell you. Now you have asked, so I'll break for about 2
It
minutes from the normal subject, and then I'll let you know. It's not just water which takes it away. Okay, it is the circulation. Water also needs circulation, isn't it? Do you think that drinking water, it will remove the lactic acid in general? In general, no, it cannot remove, right? Anaerobic water may not work. We need a proper circulation to do that. So if you talk about it, I can tell you the because I have come from, of course, muscle damage theory of delayed onset of muscle soreness. Just 1 minute, I'll check the chat box too. Okay. Okay, no problem. I'll explain this, no problem. So what happened? These kind of damage or ruptures minute lesions. Everybody agree, but these are muscle sarcomere. Anybody remember? Z
So
line
can
of
you repeat?
sarcomere.
Your voice was
yes,
Okay,
breaking.
no
What
problem.
is the
We'll not go
question?
so much deep.
it is a unit.
I was telling that Z line of sarcomere.
It is the
Okay,
structural and
where the
functional unit.
microscopic, where the minute lesions happen during the soreness is a Z line of muscle sarcomere most of the time. Okay, so the soreness we say it is to increased tensile force and muscle lengthening from the eccentric exercise. Now you are confirmed because you told me it is due to the eccentric exercise most of the time, right? So eccentric exercises, whenever what happens in eccentric exercises, muscle lengthening takes place. Isn't it true? Muscle lengthening takes place. So during the muscle lengthening, tensile force also increasing, and there is a trauma on the Z sarcomere. That is how it gets the painful sensation, right? So it may cause the both muscle fibers, like what you said, the actin and myosin cross bridges to have a what we say to get separated prior to get relaxation. Okay, so this is how it happens during the eccentric exercises. So it actually increases the risk of I can tell you the damage to sarcomere, the muscle fibers, more and more. Okay, when this kind of repeated trauma happens, I can tell you to the particular muscle, these pain receptors, what you say the nociceptors, basically within the muscle tissue is causing the pain. That is how the overall theory of DOMS is. But it is not only the one theory. There is one more theory. I'm not sure whether you know. That is called the enzyme efflux theory. Are you aware of what is enzyme efflux theory? Anybody? Enzyme efflux theory? Since Dr. Sweeney asked about this, so I just wanted to explain it. Enzyme efflux theory. Anybody is aware of? No, no problem. You would have heard it or you would
No,
have
sir.
read it, but you would have maybe you're not using, so got forget. So it's something like like generally due to trauma, especially the micro trauma at level of muscle, your calcium, which is in the endoplasmic reticulum, which you say the sarcoplasmic reticulum, uh, that is stored. Okay, so that get accumulated in the damaged muscle tissues. Okay, so normal respiration is inhibited and ATP is needed to actively transport the calcium back into the sarcoplasmic reticulum. That also gets slow. So calcium influx is getting slowed. Okay, so accumulation of those calcium may activate some enzymes like phospholipid, phospholipidase, and phospholipase, in fact. So these enzymes are responsible for further breaking down the other muscle fibers, or it is responsible for further degenerating, further breaking down the degenerated muscle fibers. Yeah, Sapna knew this quite well. Yes. So this is how it causes pain, and in turns it is of course there are a lot of cell mediators like prostaglandins, potassium, or histamines also, which accumulates. Okay, this is how it causes the pain. But here the pain intensity won't be like the day one. Pain intensity will come, and then an average will be maintained. Okay, so as I told you, the lactic acid theory, this theory is also there, but this theory is something is running since ever since they got ATP and lactase and these all are there. But more than this, we think that it is a contractile portion. What I told you, the enzyme efflux theory and the damage of the tissue, what happens, actin and myosin cross bridges problem, these all. So considering that, forget about lactic acid theory for some time. Considering that, if we do the dry heat application, we try to bring more and more nutrients to that area to repair that particular tissues. You got point? Ice will inhibit the circulation and it will not repair those tissues. Okay, say for example, lactic acid, let us forget for some time. Calcium, I told you some of the enzymes which actually hinder the muscle tissues. So here we are using the dry heat to increase the circulation so that more and more nutrients come and it actually build up the muscle fiber better. Ice cannot do that. Ice can decrease just pain. But here with the heat, we can have the effect of rebuilding the muscle tissues. Now is it clear, Dr. Aswini?
Yes, sir. Yes, sir.
No, I mean, if it is not clear, again, I'll explain. I think my student Mayuri knows that unless anybody has the convincing part, I will not leave generally. So I'm telling you that when it is a DOMS part, okay, it is not just pain we have to reduce, we have to build up the muscle fiber. So first try to understand why DOMS happen. It's not just lactic acid part. In fact, lactic acid is normally we talk with the student in general. Earlier, this kind of thing was more, but later, since you asked me deeply, so I told you about this all enzymes and then mediators like prostaglandins, histamine, and of course the potassium also, which comes out and damage already damaged tissue. This is how the pen doesn't go. So we want heat to bring more and more nutrition as well as more and more flow to remove these substance, what we say the P substance, the pen creating substance. You would have read in the book of Calitan and other things like that. So this is the whole theory behind using the heat for the domes. So writing this one sentence, I have studied for more than 30 pages, probably. Dr. Suni, if you have any further concern, we'll talk later. No problem.
Okay, sir.
Yeah. Fine. So this chart you can go through. This chart I have given all the effect of the heat. Okay. So you can see one by one and then can let me know. It is bit complex chart, but once you know this, it's very, very easy. First, I have given that what happens and then how it happens and how it works for the pen relief. So it's not just seizing the receptors. We can reduce the pen. We can reduce the pen also softening the scars, stretching the collagen fibers, stiffness, decreasing the stiffness, decreasing the muscle spasm, or analgesic effects many a time. We can sedate the skin, or we can what we say that we can actually use the behavioral configuration also of the body. Now connective tissue effects, everything I have given in that this one, you can just go through that easily. Yeah, physical principles, if you talk about the heat flow through the matter tissues varies with the nature of the material, types of tissues, and is called the thermal conductivity. Okay, changes in surface tissue temperature from heating modalities depend upon the intensity of heat applied, time of exposure, thermal medium like product of thermal conductivity, density, and specific heat. This you know very well. Now, greatest elevation occurs in subcutaneous tissues within 0.5 to 2 centimeter of skin surface. At a depth of 3 centimeter, using clinical tolerable intensities, muscle temperature elevation can be expected to be about hardly 1 degree C. Heat transfer, you know very well, conduction, convection, radiation. Understanding is very easy. Conduction means the heat through the metal or any solid. Convection is through the bulk movement of molecules. That is possible only when there is something called the liquid, so boiling of water. But radiation, it doesn't involve any medium as such. Okay, it actually the conversion of heat energy in the form of what we say that to the electromagnetic radiation. So that is how the IRR lamp work. Okay, it actually radiates the infrared range that creates the heat, right? That creates the heat, infrared rays. Okay, well, so so conductive heat modalities. Okay, there are many hot packs. I mean, superficial heat modalities and deep heat modalities. Like superficial is like hot packs, whirlpools, paraffin baths, infrared lamp. Skin temperature rises, but subsequent tissue decrease is normal. Suppose somebody is giving me heat on top of this part may not increase in the temperature. Okay, so 1 centimeter penetration you can expect. Okay, depth of penetration, again it depends upon the fat in the area. You can't expect with the same heat or depth of penetration on the shoulder, elbow, wrist, and the hip will be same. No, it cannot be. Deep heat, ultrasound or diathermies, here it goes up to 5 centimeter of penetration, not most of the time. So theoretically 5 centimeter, let us say 2.5 to 5 centimeter in general, it goes through the superficial tissue layers. So contraindication, of course, you know very well: acute inflammation, decreased sensation in area, impaired circulation, unable to dissipate tissue temperature rise, and malignancies. Never ever use it. Then, of course, pregnancies. Moist heat packs. Okay, moist. Majority of you seen that. Have seen it. Canvas pouch with silica gel. Pack is kept in a water-filled heating unit maintained between 160 to 170 degree Fahrenheit. Pack maintain temperature of 30 to 45 degrees C. Packs transfer heat by conduction. Main benefit is superficial heat to 1 centimeter. Now, I have given the setup part also. How do you do that? So in that I have given the duration 5 to 6 minutes of comfort, 3 to 4 hours minimum between the 2 treatments of the day. So I would like to know from you, where do you use generally this moist heat? Please, everybody here, you can unmute and you can answer. Where do you use generally moist heat pack?
For any mechanical pain.
Mechanical pain. Okay.
For back pain, so for the back pain usually.
Okay, but what type of pain?
Muscle pain?
Yeah, the somatic
Muscle pain. Okay. Anything else?
The somatic pain.
Somatic pain. Somatic pain is a big puzzle. Okay, fine. Somatic
So
pain.
mostly superficial type of pain.
Okay, well, okay, fine. These all things are fine. I'll give you one example. Very simple. You will only tell the answer. I know very well. Suppose somebody has a elbow comminuted fracture of elbow, and the person was done the K wire. Okay, I mean, I have not got fracture by God's grace, So, the K wire has been fixed for that. The many pieces which was coming out, and then of course there is no nerve damage, nerve was not compromised. So now doctor has told to go for physiotherapy. Okay, but the range of motion is 90-degree fixed. It looks like a fixed. So what are you going to do? What are you going to do?
Hot pack, then we'll go for mobilization or stretching. First, we'll go for hot pack.
Okay, of course mobilization you are able to do it, but how will you do it? What kind of heat will work more here, moist heat or dry heat?
So moist heat.
Why?
Moist heat.
That's what I'm asking. If it is moist heat, then why? If it is a dry heat, then why?
So the reason may be.
So that could be the facial adhesion,
Okay.
because it's a superficial thing which is might be tightened. Sir?
Okay. Okay.
So we need to increase the tissue repair and formation of cells as well.
That is anyway
That's why.
goal we have, but of course you are right. Moist heat has to be done. That will be having a better effect. Yes, Rajiv ji. Anything? Yeah, you are right. Moist heat works here really well. You can't do wax. You can't do wax.
So it will
And
soften the tissue, hard tissue.
okay, so you can't do, of course, the wax. You can't do dry heat because there is a K wire inside. Of course, it won't be heated enough, but again, you know very well that dry heat has better transfer than the moist heat.
Yes, sir.
So you are right. Moist heat has to be used, and moist heat will have a better implication on
Yes, sir.
already tight the bicep. But here I'll give you one more tip. Anybody, if you see with this kind of fracture or any kind of this, there is something called end feel. Okay, end feel. We actually try to assess the end feel. What is the end feel? When we are, if you want to know more about end feel, go to the book of Maggie. I mean the orthopedic assessment by the Maggie, very popular book. If you don't have, my library will help you. So when you are applying like this, you have to check what is the end feel. Is it the end feel bicep which is holding? Is it a tissue? Is it a bone? What kind of end feel? Okay, once you know the end feel, I'm telling you, this kind of fracture works very well with the moist heat. Very well with the moist heat. Many cases people go with the ice and do it, but I'll tell you, this kind of fracture, again, if coming to the evidence, it's always good to go with the moist heat and then do it. Now, second example, second case history. Let us talk about more case history, more this one doctor from America. I mean, he worked whole life in America. Then what happened? One day he came to Bangalore and got settled here. I'm not sure whether he's still alive or not, but in age of 79 he settled here. Long coat, like American system, and he's the only one doctor who was always asking me, what are you going to do with your patient, if he's giving me any patient to do that. So once he sent me somebody with the cervical spondylitis, very bad case, and he asked me, what are you going to do? I was a bit fresher that time. I think I was in masters or something. So I said, sir, I'll take moist heat and I'll apply over here, okay, in this part, because I found that is having some spasm. So I'll apply here, I'll relax the part, then I'll go with the exercises. He was highly impressed. Now I want to know from you people, is it really the good approach? He appreciated me anyway, but is it really a good approach? Very bad case of cervical spondylitis, I'm telling you. Stiff neck, not much range of motion, having some pain over here shoulder also, but more pain in the upper trapezial region, and numbness in hand, of course. I said that I'll definitely do the movement, but I'll first relax him with the moist heat. So was it the good suggestion I was giving? I mean, is it really holding some ground according to you?
So for any patient, first priority is to reduce their pain. So maybe that's how it works. Like whenever a patient comes, our priority is first to reduce the pain and then treat him for the rest of the things, like maintain his range of motion or anything. So I think you are
Okay,
right in that aspect.
okay. Dr. Aswini, is it okay? No, why did I think about it? I'll tell you. I saw his prescription. It was a wonderful painkillers had been already prescribed. So I thought anyway pain is reduced or pain is going to be reduced. So let me use the moist heat which will relax his muscles and give some movement. That is what my idea was there some 8 years before, 9 years before, 10 years before. Nothing else. But now, if I realize those case histories by seeing my old book of records, I feel that I was correct. Okay, nowadays, of course, you have a lot of dry needling and cupping and all, lot many things you have. You have different things, but trigger point release or something. But in my time, it was not so well tout everywhere. Dr. Aswini, so putting the moist heat, it will relax the muscle and I can go for the better exercise, means the better movement. So the doctor told me, since he was working even in the US with a very good close association with the physical therapist, he said like reduction of pain first, then you go for the range of motion, then go for the muscle strengthening. So it's not about what you goal, it's about how, whatever the goal you have, what is the sequence of goal. Now I can't expect the muscle strength without reducing pain. I can't expect, as Mayuri told, like reduction of pain is the first. So I saw in the prescription, nice painkillers has been given. So my duty starts from the day, I mean, what you say, the stage two. Stage two is to relax his muscles. It was very like tightly hold and those things. And it worked for the patient. After 10 or 12 days of treatment, he was really he was really good. Okay, so it was a case history discussion, and I'm knowing that every patient is different, every treatment is different, and the response of the treatment to every patient is, of course, different. So there is an indication and contraindication I have already listed over here. You know very well. You please go through this in the manual, and after that we'll talk about paraffin bath. Okay, 7:1 should be good, should hold good for the wax to oil ratio. Everybody knows this. Wax, glycerol, and paraffin combination. 118 to 226 degree Fahrenheit. Sorry, 126 degree Fahrenheit. There is a mistake. I'll correct it for upper extremity, and then 113 to 121 degree for the lower extremities. Okay, paraffin can approximately 6 times, provide the heat as water due to the low specific heat. Specific heat, everybody knows about specific heat, or should I explain? Well, I think you know that. Okay, used to deliver heat in uniform amounts to small irregularly area like hand, foot, wrist, fingers, everything. And this is how, what is the disadvantage of wax therapy, that you can use only for the extremities. You can't use for the larger body area. But okay, again the case history. Let us talk about case history again. A person with rheumatoid arthritis, okay, 10-year old disease condition comes to you, okay, cloud finger. What do you think? Giving the dry heat is better or paraffin bath is better? Anybody can unmute and answer. Nobody's online?
Usually it is the wax therapy, whatever is suggested, even since our BPT level, that's what they say.
Cool. So wax therapy, only thing that you have to check your contraindication and
So,
yeah,
so
not audible. Please come in the better contact.
paraffin wax will soften the hardened tissues. So paraffin wax will soften the hardened tissues.
Okay,
So it will be preferred
preferred.
up to
Okay.
my knowledge.
Yeah, you're right. You're right in saying that. But I will tell you something better than the paraffin wax for rheumatoid arthritis. I'll let you know another 10 minutes. But you know that wax therapy is again having some copyright on the joint stiffness. Okay. And let me tell you, suppose a bowler, you want to train in spin bowling. Okay, spin bowler. You want to make him the spin bowler. At wrist, you can do proper waxing and you can practice this because in spin bowler you need flexibility with strength, isn't it true? So you can use the wax therapy for training your spin bowler. I just gave you an example like that. If somebody coming for the different kind of play, you can just see where you need more flexibility with the strength. Please train that. Please train with the wax therapy. It is a tool which will give you better effect. Everybody's okay with this? For more knowledge, you can go to the basic book of I think Maheshwari, where he has given
Yes.
the orthopedic this one book. I think in that they have given the detail this wax therapy, beauty beauty of
So,
wax therapy in spin
but
bowling.
what
Yes.
is it necessary to give wax therapy for spinning the ball rather than giving a stretching for them?
Okay. Good. See, uh, did you listen what I said? Complete sentence. If you listen, you would have heard definitely, but I think you are missing the point. I said there is
Okay.
something called the flexibility that you can
Okay.
attain definitely with the stretch. Clear? Now
Okay.
I said flexibility with strength. True? Strength you
Okay.
can use the endurance and then of course your strength training you can get it done. Then what is the use of wax? Of course, somebody told, I'm not able to locate the name in my screen, but somebody told that it loosens the heart tissues. Really? Now go to the basics of biomechanics, chapter 3, Cynthia Norkin books. Chapter 3, right? Yeah, I think chapter 3. There is a subject of elasticity. I mean, there is a chapter on elasticity, isn't it? It is there?
Yes, sir.
Yeah.
Yes.
So elasticity, when we talk about elasticity, we go for like a
Yes, sir. Yes, sir.
length, increasing the length, what we denote in maths like a DL, the change in the length, delta L. Okay. But there is a
Yes, sir.
limitation of stretching, isn't it? That we say the elastic limit. You agree?
Yes,
There is
sir.
an elastic limit for every soft tissue. Oh, well,
Yes, sir.
what do we do with the wax? We try to attain some 5% extra elastic limit. So 5% extra flexibility. Got my point? Stretching can't give you that particular. So we are trying to increase the elastic limit. You see here. Dr.
Wouldn't be
Besnet,
temporary.
sorry?
Wouldn't be that temporary, sir.
No.
Or
I'll go again more basic.
okay.
I'll come to class 11 now. There is something called the structure. There is something called the function. Isn't it true? So structure and function in the nature went to complementary to each other, isn't it? So if you have a structure, you can get the function. Or if you are having a function, you will get the structure for you. I mean to say, as a human being, we have come from all the way from bacteria to everything. I mean, yeah. So when we were avian birds, we had a beautiful flying mechanism, isn't it true? Later, monkeys have 4 legs, right? Some monkeys came down and started walking on 2 legs. They are the lineage of the human being, right? So if you change the structure, function will be better. And as you're talking about temporary stuff, let me tell you, as you talk about the temporary stuff, 100% it is true if the person stops practice. If he stops practice, no use, structure will be back. Correct or not?
So when you say 5% extra elastic limit is attained with this wax bath, does it hold good for even the dry heat? Or I mean, now we have like superficial heat, deep heat, and in the superficial heat also we have something called as dry heat and moist heat. So does it hold good for all the heating modalities, or is it only for the wax bath?
This is something for the okay, this is something holding good for the paraffin much more. Reason behind why are we using, madam, this paraffin? We are using to soften the skin, isn't it? We are
Right,
using
sir.
to soften the skin. This element is not present in dry heat. Correct? This very element is
Agree.
not present in other form of IRA or any kind of dry heat, right? So
Yes.
this element we are using to trying to improve our slickness. I mean, the increasing the limit of our own soft tissue. Clear my point?
Okay, sir.
I'm talking
Yes.
something better than average. Of course, the person, you are very much right. The moment he'll stop the practicing, he's out of the field, taken sannyas, what you say, retirement. After that, of course, he can't, if he's not practicing, it is gone. But at this point of time, when there is a training going on, in that training, we are using that paraffin to increase the limit. That is possible.
Does it hold good for deep heating modalities as well, sir, like the diathermies or
Okay, diathermy is not in today in
ultrasound?
the detail in the subject. Of course, it's not possible because I want to show different position that is possible only in the physical event. But
No, my only
yeah, you're
question
right.
is how do we differentiate it?
You're
So
right. You're
that's all.
right. Let me tell you, the dry heat. If you see about the diathermy, if you see, diathermy is basically the large amount of area is under application. Is it true or not?
Yes, sir. Large and deep.
Large and deep, right? And then temperature
Yes.
we maintain there for longer time. Isn't it true? So they have tried the diathermy in sports, no doubt about it, but it hasn't given enough effect. Wax is so much temporary, I mean, sorry, so much localized, that localized effect you won't get in diathermy. Clear about it?
Okay.
Localized effect is the story here. Wax has a beautiful stuff on treating to the patients also. I'm sure you would have been seeing the difference, the wax therapy, when they do, like how stiffness reduce after some time. The only
Surely,
thing,
sir, because when we were in BPT, maybe like whichever patient walks in, first it is wax, only then mobilization.
yes,
So
true.
it was always wax for us. So
We have also grown up like that. Nowadays, they have a different system, but we have also grown up, like wax used to be one of our mainstay of treatment. So now there are a lot of things. So yes, Dr. Sapna is writing, yes, sir, during the clinical trials. Yes, it's into the trial, but I don't have enough evidence, so I will not tell that diathermy is actually, yeah, but one tip I'll give you on diathermy today. It's very good for somebody told no mechanical pen earlier. I'm telling you that postural pen and mechanical pen, if you don't have any contraindication for your short wave diathermy, please use that. That's very good for the postural pen and mechanical pen. The reason is again same. It gives the large area and deep heat for longer time. So say for example, if I am having the lower back issue just because of sitting in the office for 10 hours in a row, what is happening here? Large large area and depth of my muscles are into trouble. Okay, I will again make it more specified. I'm telling you, back has a layers of muscle. Isn't it true? Back has a layers of muscle, right? So in diathermy part, it goes deep and it maintained in a large area. So your all eccentric muscle, which is of course the back muscles are eccentric activity muscles. So that gets the proper amount of circulation for longer time. That is how it works better.
Sorry for interrupting, sir. In shortwave diathermy, they are banning in many countries, and
Yes.
the effects of
Right, sir.
shortwave diathermy is like they are. I mean,
True.
there is calcium is going. I mean, what to say? So I
Tell,
mean,
tell,
the
tell. You're right.
effect.
You're right. You're right. Calcium.
So, mm, there is no use of talking about shortwave diathermy,
Reason
right?
behind that I have not added in my this one my subject today, because many countries, because other countries also students today. I don't think anybody has joined from other country, but most of the time I have people from Africa or somebody. So I don't know which country which is permitted. So I tell very clearly, look, see your country. If it is permitted, you use it. Otherwise, don't use it. Very simple. Because
But is it
there are
not
a lot
true
of
that it has
contraindications. Forget about
hazardous effects, sir?
it. Has anything having a radiation more will have definitely
Yes, sir. It
hazards.
has radioactive effect, and
It has
yes,
hazards.
sir. It may be carcinogenic as well.
Again, carcinogenic. Okay, anything is
Is
carcinogenic
it
if you see a
true,
lot
sir?
of
Because we have been hearing this since years.
yeah, fine. Let me tell
Uh,
you, uh, we have more content, we have to finish, but I'll give you this idea. Anything is carcinogenic, you say, anything can turn into carcinogenic, okay, if the stimulation is very constant and repeated. My teeth is not good, okay, it is having a pokey, say for example, anyway it was true too. So if it is hurting my uh, like what we say that tongue for quite long time, hurting my tongue or my soft palate for quite a long time. So after many more years, maybe 8 years, 9 years, depend upon the person again, and how much is the hurt. So hurt is more and more and more and more. So my squamous epithelium will no more will be able to produce that cell. Now come to the lungs, smoking. Okay, do you hear anybody smoking for 3 4 times and get cancer and get hospitalized? No, it doesn't happen, right? Lung squamous epithelial cells takes long time to convert into the fibrous part, right. So after that, I told you, switching on and switching off mechanism. The moment it is a switching off mechanism, the cell will go multiplied, it will blast into multiplication. So uncontrolled mitotic division of the cell, which is giving the cancer position, benign and then malignant. You got my point. So it is possible, diathermy radiation for long time, if it is going, it is possible, it can happen. Clear? Stimulant, what we say irritant or stimulant, is the factor. Contrast treatments used as transition between cold and heat. Everybody of you are thinking about still carcinogenic. Come out of that. Okay, Lal Krishnan is saying that happens in Europe. People use this by themselves without any control. Okay, I did not know this. Fine. Use just as transition between cold and heat, allows types of vascular pumping via cold and hot treatment. Many use water or ice packs, hot packs, etc. Many may vary the length of time in cold versus heat depending upon the effect right. Ending of treatment should reflect effect you want to end up with. Setup, you can go with the two tubs. I think majority of you have practiced this, and maybe many of you would have got bored and after that you never used it. Probably, but it is one of the good treatments. Since very old time we are trying this. So two tubs you place as close as possible. Fill one tub in the range of 105 to 110 degrees C, another maybe 50 to 60 degree Fahrenheit. Position the patient on chair or bench between the two tubs. Heat treatment given first, then contrast bath 20 to 30 minutes at 3 to 5 minutes interval, or a combination of 3 minutes hot, 5 minutes cold. Like that you have to do. Okay, anybody has used contrast bath, and if they have used, for what condition you have used it? Anybody has used? I'll check the box. No. Okay, you can use for the chronic swelling in leg. Say for example, person had a fracture about 10 years before, still he has some swelling. Try that, just try that once. But consider his BP, his kidney problem, everything you consider, and then you find out if one leg is swelling like that, the very old chronic edema in the ankle which is not going, pedal edema, Please try that. It will work. Okay, now we'll be talking about fluidotherapy. I think rheumatoid arthritis is back. I'm telling you, rheumatoid arthritis is one of the conditions which can be treated as well as which can be addressed very well with the fluidotherapy. What is fluidotherapy? It's a kind of box type of machine. Okay, you can see on the Google this image. A dry heat modality that transports heat energy by forced convection. So there is a like a it comes in a variety of sizes and are best used for distal extremities. So you have to keep your hands inside it. For joint and distal parts, patient place body parts to be treated through entrance sleeve of fluidotherapy. The sleeve is then secured to keep cellulose particles from escaping. The air stream is blown in and the particles become suspended, and treated body parts feel that it is immersed in a fluid like a whirlpool. So temperature is maintained somewhere between 39 to 48 degrees C. Lower range are recommended for those having greater predisposition of edema formation or may not be able to sustain high temperature. Okay, if there is a edema issues, don't do higher temperature. Distal extremities can be put under the exercise inside. Okay, you can tell the patient to do like this, or extrinsic and intrinsic muscle exercises you can do. And apart from that, it can be done like immediately do stretches immediately following immersion. So if it's coming out, just go for the stretches. That is very, very important. Okay, so fluidotherapy is the best thing to use for your rheumatoid arthritis patient. So those getting more arthritic patient, especially rheumatoid arthritis, if you have a good, kindly purchase this machine and use it. Contraindication and precautions, keep in the place. Application over the area with lack of sensation, you should not do it. Application over area of vascular insufficiency like a Raynaud disease or something, you don't do it. Recent hemorrhage or potential hemorrhage condition, don't do it. Over non-malignant body part, suppose some malignancy is there, don't do it. Acute inflammation, never use it. Infection, never ever do it. Why? Because if you use for one person having infection, the another person can get infection. And then application over areas where recently ligaments or hot packs have been applied, don't do it. Anybody rheumatoid person coming to your clinic, you are using the wax therapy also and you are using the fluidotherapy, it will not work. It will not work, I'm telling you, because there is a limit of tunica media to expand. There is a limit of elastic, what you say, that connective tissue of the blood cells to expand, right? You can't expect more than that. There is a limit for everything, that is called the elastic limit, right? So application in any situation deemed unreliable by practitioner, like the language difficulties, the patient coming to you is knowing only French and having a rheumatoid arthritis, want treatment, and you don't know French, kindly don't use that, because the language difficulties can make into can buy you risk. Don't do that. Clinical process application I have given here, same like this. Check for contraindication. I always say people, if you are going through the steps, go for first contraindication, check for the contraindication, what not to do, then consider the risk, then you come to the conclusion, okay, now we can do it. Once you are done, yes, we have to do it, then position and instruct the patient, prepare the treatment area, select the type of modality, whatever you want, high, dry heat, moist heat, whatever, then determine and measure the doses, temperature of the agent, temperature of the skin, make that. And after that, wrap up and use the pack, apply treatment, measure the thermal skin heating, how much heat has been. So before the temperature, before the treatment is started, after the treatment done. After doing that, post-treatment procedure like inspect treatment area, record any adverse effect, unwrap the unit and keep it back. Simple, very, very simple, finish it. Ensure post-treatment equipment maintenance. As I told you that you should always spray with the sanitizer and keep it with you. You should not keep in general. So sanitizer spray also preferably when the heat becomes normal. Clinical decision making and execution of intervention, very, very important. Assess the patient, establish intervention goal on results of patient assessment and evaluation. Select intervention plan including thermal modality when applicable to meet these goals. Choose thermal modality, select position for intervention, apply thermal modality followed by exercise or other appropriate techniques, reassess and determine if interventions should continue or be modified or discontinued. Established a home program, which is very, very important. You can use the thermal or ice things modality in the home treatment with the exercises he or she can do at home under your supervision. If possible, join them online in a week and then just find out whether they are doing correctly or not. Ensure that your patient problem is your property. So any patient is paying you say for example amount of 1,000 rupees or whatever, but think that if it is a 10 times amount he pays, what kind of treatment you can do. If you can do that sort of treatment, please do that sort of treatment, that sort of service, you do that. If If you give the service in that level, tomorrow money will come. That's a different thing. But your talent will maintain your standard. Okay. Anyway, next is the therapeutic ultrasound. Again, the very big chapter. After that, we'll have a current, even bigger than that. So we are lagging behind the time, so I won't break it here. Let us continue this. I'm sure everybody is agreed with that, because we are lagging behind the time. We will not break here. Otherwise, I usually give break between these. Okay, biophysical discussion. Let us talk about something about biophysics. Sound is a vibration that typically propagates as an audible pressure through a transmission medium such as a gas, liquid, or solid. So your hearing capacity goes somewhere between 20 and 20,000 hertz. Okay, below 20 hertz is infrasound. Above 20,000 hertz is ultrasound. Characteristic. If you talk about characteristics of the sound wave, you know very well wavelength. Wavelength is nothing. Is a distance over which the waves shape repeats. Okay, frequency, number of oscillations, amplitude or loudness means measure of its change over a single period. Quality or timbre, timbre. Let us talk about timbre. Timbre is the quality of sound which allows us to distinguish between different sound sources producing sound at the same pitch and loudness. Properties of sound waves. Let us see about transmission. Sound can transmit through a medium such as particles in the air. Speed in air is 340 meter per second. Just one second. Yeah, 340 meter per second, 1500 meter per second, and in liquid, and in steel it is about 6000 meter per second. Reflection, change in direction of a wave at an interface between two different media, but the reflection happens in the same media. Follows both basic rules of reflection, you know, sine law. Refraction, change in direction of acoustic waves when it passes from one to another medium. You would have seen, if you keep a okay, fine. Refraction, I'm talking about refraction of sound. The stethoscope work on that, right? It actually follows the Snell's law. Ratio of sine of angle of incidence and reflection remains same in the media. That is called the refractive index. It holds good for the light waves too. Diffraction, it's a change of direction of acoustic waves as they pass through different obstacles, okay, or apertures. Okay, aperture means nothing, is a kind of hole. So we easily hear around the corners and walls and open windows and doors. So diffraction of sound is really good. Really good to learn. And if you want to know diffraction of light, many of you know about it. Diffraction of light. If you are in the night, you are traveling, you find the red color more in the sky. Okay. That's all. The absorption. Acoustic absorption refers to the process by which a material takes in sound energy. Very important. This absorption part is something to be learned by physio. Absorbed energy can be transformed into heat and transmitted through the absorbing body. The fraction of sound absorbed is governed by the acoustic impedances of both media and is a function of frequency and incident angle. We'll come to that. Sound absorption coefficient is the fraction of sound energy absorbed by a material. Absorption coefficients are tissue and frequency specific. Every tissue, it will have a different absorption. You can't expect the same absorption in every tissues, even with the sound waves. Higher with the higher collagen content tissues. This is the key. You have more collagen content tissue, higher the absorption. Increase in proportion to the ultrasound frequency. Today onward, your approach to ultrasound is going to change. You will decide your dose according to you, what you learned today. So you see, there are many tissues over here. Okay, 1 megahertz ultrasound and 3 megahertz. General clinically we have two types of, right? So this is how the factor it is getting absorbed. I have given in the manual also. You can just go through this. Yeah, scattering, very important. Why your sky appears blue? Because of scattering of violet, right? So a general physical process where some forms of radiation such as light or sound are forced to deviate from a straight trajectory by one or more point. Okay, this can be due to localized non-uniformities in the medium through which they pass. Attenuation is nothing, it's a result of absorption, reflection and refraction. So for physio, knowing attenuation is more important. Absorption accounts for 1/2 of attenuation. Attenuation coefficients are tissue and frequency specific, as I told you even earlier. More the collagen, more is attenuation. So blood is 3% and bone is 96%. Now let us talk about the schematic diagram. How does it work? I mean, the grating circuit, you have a power supply, then you have a 1 megahertz sine wave generator and amplifier. Then the wave goes to the crystal. Crystal is like a piezoelectric crystal, which is held in a metal hand, held probe, and that is how it converts into the energy. This is how the production goes. Most of the time 1 or 3 megahertz are more into the use in the market. So wavelength, if you calculate, it will be 1.5 millimeter for 1 megahertz and 0.5 millimeter for 3 megahertz, because if you do the product of frequency and wavelength, that's how the velocity comes. I mean, everybody must have been knowing about it. V is equal to n lambda. There is a formula in physics. V is equal to n lambda. Velocity of sound is equal to frequency into the wavelength. That's how. So according to that area. Now, very important concept I want to discuss. I will not tell which company ultrasound you should purchase and use, but today onward I'll show you. Since I'm not in my clinic, otherwise I would have shown you the clinical ultrasound part. Look, if you take the ultrasound head, right? If anybody comes to you and say, sir, my ultrasound is so great, kindly purchase this, I'll give you this discount, that discount. Two things you ask. First thing, I want to see your head, ultrasonic head probe. Yeah. And second thing, how much service agreement you can go for. Any electrical equipment, ask for service agreement, because you never know if the parts goes wrong, anybody will be able to come and do that or not. Don't go for money, go for service agreement part. Very important. Now take the ultrasound head and open it slowly. Most of the ultrasound which comes from the good company, I'm again repeating it, from good company, is openable. You can open it easily. It's just on the screws or maybe some holding kind of stuff. So once you open it, you find a spring kind of thing and kind of coin which is attached over there. How many of you have opened the ultrasound and checked till now? Anyone?
We had opened it when we were in BPT, sir.
Anything you remember there? No. Okay, I'll tell you. You'll find a coin shape of thing that is a piezoelectric crystal. Okay, you know, there are ultrasound, I will not comment on the companies which comes with such a big head. You open it and then you find the reality. The reality is the blue, which is I'm shading in the screen, the blue color in a concentric circle including the black. So transducer face is so big, but the real crystal is so small, right? So this we say the ERA, very important concept for ultrasound, effective radiation area. Area of the sound head that produces ultrasonic waves, expressed in square centimeters. In general, always lesser than the area of head side, of course, because it is enclosed in the head. Large diameter heads, column beam. Okay, small diameter heads, more divergent beam. I'll come to that picture. You'll come to know this mathematics also very clearly. So low frequency like 1 megahertz is diverged than the 3 megahertz. So tomorrow if somebody coming and saying you, sir or madam, please take 3 megahertz machine from me, nobody uses in the market, you should understand it is a diverge. It goes like this. Okay, but when it is 1 megahertz, it will go like this, even more diverge. Okay, so diverge, if it is needed or not, that you will come to know in later part. Now, beam non-uniformity ratio, very important. I think I have made some spelling mistake, I'll correct it. Beam non-uniformity ratio, BNU ratio. Okay, it is a physics. There is a term called special peak intensity, the peak intensity of ultrasound output over the area of transducer. Just on the head of the transducer, what is the intensity? And a special average intensity means when it starts traveling over the area of transducer, what is the average intensity? It will of course decrease. Why? Because intensity can't be same through the tissues, right? Through the tissues it will go decrease. But how does it decrease? How does it decrease? So you should ask the question to the ultrasound person who comes to sell you, okay, what is the B and R? If you say that BNR, I don't have idea, you say that you find out from your company. If you say that BNR, they are saying about 10, don't take it. Don't take it. You should take always when it is less than 5 or up to 5 is okay. So good European companies or any good companies in India will tell you what is BNR value. So BNR value less than 5 is anyway good. See, this is the BNR. Now everybody can see this transducer. The moment energy comes out, it will start decreasing the intensity because of the tissues, right? So spatial average intensity is remain about 1 watt per centimeter square, and then peak will be 5 watt per centimeter square. So if you take ratio peak to average, it will be 1. So below 5 is always good. That is what we say, it is always good. I have taken from some source I will reveal. Type of ultrasound waves, either you can go for continuous or pulsed. Everybody knows this. Continuous will be like this, pulse will be like this. Okay, now there is something called spatial average temporal peak intensity, what we say SATP, and then a spatial average temporal average intensity like SATA. So duty cycle, you choose the duty cycle, 1:1, 1:4, means what? One time, I mean the part of time what is said 1 is where your intensity is going. Okay, and part where it is not going is 4 times bigger than the 1. So if you calculate it, duty cycle into spatial average temporal peak intensity will be spatial average temporal average intensity, SATA. Okay, anyway, this is not very important for you to ask the question from the person you purchase, but it is for your understanding. Okay, next, this is very important, again, understand that. This diagram I have taken from Holland East Yorkshire Hospitals, this one, but apart from this diagram differs in different phase. Okay, so there is something called near field and far field. You must know about it. There's a formula, there's a mathematics formula. Near field length is equal to a square by wavelength. So wavelength, you know, if he is selling you 3 megahertz ultrasonic head or ultrasonic device, you know the wavelength is 0.5 nanometer. Clear? Now radius of transducer. Okay, so take the measurement of radius of transducer, square it, means just multiply with the same and divide by the wavelength. Whatever you get, that is the near field length. We say that near field is Fresnel zone. It is convergent. Here I have shown the parallel, but make sure, dear participant, it is bit convergent, good for you. And then there is something called divergent range, that is called the Fraunhofer zone. I'm not sure how many of you are interested with space physics. If you are interested with the space physics, you would have heard about Fresnel zone and Fraunhofer zone. Okay, if you are interested somehow by any which way, maybe with your family members or whatever, but you'll be knowing about Fresnel zone and Fraunhofer zone. Okay, Fraunhofer goes divergent. Okay, but when it is the Fresnel zone, it is bit convergent. Sorry, but NHS stressed, I have shown this image. This is a kind of uniform, the real ultrasound wave, but it is bit convergent. It's never divergent. But when it is a far field, it is divergent. That is how is the theory. So NFL, I gave you the formula. So these all are the technique where you can catch your people easily. Acoustic impedance. Okay, well, I have given the table about it. It is a measure of resistance of particles of mediums to the mechanical vibrations. Standing wave, when reflected, now you will learn what you are doing in your clinical practice. When reflected, ultrasound meets another oncoming wave, standing wave, hotspot, what you say, may be created, which has potential adverse effect on the tissues. Okay, so we never keep the ultrasound at one place. We keep moving. Okay, such effects can be minimized by ensuring that the apparatus delivers an uniform wave using pulsed wave and moving the transducer during the treatment. Okay, using the pulse wave is always good for your machine, and of course for the tissues too. Half value depth. Half value depth is nothing. It's like a half-life kind of formula where the you have to calculate the tissue depth where the 50% of ultrasound is delivered is absorbed. So 1 megahertz and 3 megahertz machines will be differently seen. You can see I have given a small table here. You must go through this and you find out your thickness, because whatever you are learning here is going to work more. Now, average half value depth of 3 megahertz machine is 2.5 centimeter and 1 megahertz machine is at 4 centimeter. Now you tell me how many of you have purchased 3 megahertz machine till now, because in market mostly it is I think 1 megahertz. How many of you have purchased 3 megahertz?
I have 1 megahertz, sir.
1 megahertz is a very common one. No, people are saying that 3 megahertz is this. You take this. This is very good. This is how. So I'm asking that. So let's do some activities. Orientation of ultrasonic equipments. Okay. Select any unit. Take a unit. Okay, and record described information below. So if anybody coming to you, you should check these 7 points. Manufacturer, who is that, whether it is a reliable or not. Then it is a last inspection date. Of course, it is a new machine, so no problem. But still you should check it when it was manufactured. Then available frequencies, either 1 or 3 or both. Available transducer size, whether you have a small transducer, big transducer, all those. And then after that, effective radiating areas. I told you know how big the transducer face is, but don't fall for transducer face. You tell him to open up and then you see real coin size. What is the coin size of piezoelectric crystal? Then available duty cycle, whether it's a chronic one, 1:1, or continuous, or it is having a 1:1, 1:4, 1:8. Always good if you have a 1:8. Don't underestimate that. That's really good. I'll let you know why. I mean how. Beam non-uniformity ratios. I told you below 5 is always good. Now locate different component and inspect them, like generator, how it is generating, and then coaxial cable. Then transducer, timer, intensity control, duty cycle control, testing of transducer of acoustic output. You know very well how to do it. Underwater test and adding water drops on the top of transducer, that you have learned very well, and then widely asked question in many of the universities in India. Physiological effects. Yes, this is where I want you to learn the thermal effects and non-thermal effects. You have studied for the passing exams, but I don't know how many of you have continued even after exams to when you use the ultrasound with the patient, like either it's a thermal or non-thermal, how does it work? So thermal effects are generally for the stretching of the collagen fibers of the tendon or capsular stretches, where you use that. And then of course you go for the decreasing in joint stiffness, reduction of muscle spasm, modulation of pain, increased blood flow. Non-thermal effects like cavitation, microstreaming, acoustic streaming, very important. Cavitation is nothing, it's a formation and growth of pulsation of gas-filled bubbles caused by ultrasound. It could be stable, it could be unstable. Stable cavitation, the bubbles oscillate rapidly, but don't burst generally. But unstable growth, like of violent large excursion of the bubbles over the many cycles, and then suddenly implodes, which cause large local pressure and temperature rise. So if the pressure is below a critical value, the bubble undergoes sustained oscillation, stable type, and if inertial force are above the cavitation threshold, then collapse with the bubble implosion occurs. So possible therapeutic effect of non-thermal effects is what? Difficult to make distinction between the thermal effects. So don't fall for that most of the time. Increased capillary density and cell permeability, increased fibroblastic activity and associated collagen production, increased cortisol production, and around nerve bundles reduce inflammation. See, I have given in the figure cavitation, how the cavitation works, forms. Then you can see non-thermal mechanical effects like acoustic microstreaming. How does it happen? Fluid and then cells. How do we push with the piezoelectric crystal, magnetic pressure? Sorry, the viscous stress. And like this is the reason that unidirectional movement of fluids along the cell membrane boundaries, it happens, produces high viscous stress, alters membrane structure and function, increased permeability to ionic influx. Then output parameters, if you check, that is the power expressed in watt, intensity watt per square centimeter, you know very well. Output frequency 1 megahertz up to 5 centimeter deep tissues, usually learn here, used for rotator cuff, vastus intermedius and gastrocnemius muscle, but does not mean that you can't use for other place. 3 megahertz up to 2.5 centimeter deep spaces, and patellar tendon, MCL, brachialis, coracobrachialis, these are places you can use this. Treatment duration depends upon your size of treatment area. Output intensity and therapeutic goals is vigorous Apart from that, vigorous heating, 1 megahertz for 8 to 10 minutes, and 3 megahertz for 3 to 4 minutes. Coupling and application. Ultrasound cannot pass through the air, so we use the gel. Okay, so coupling gel always use. Keep the area clean and then use the coupling media. Direct coupling also you can use it. Okay, like aqua gel. What generally in most of the clinics it is used. Move the head slowly. Go concentric circles. Okay, small circles. Slowly you go. Don't go like this. I've seen 80% of clinics they do it very fast, like they're making some kind of noodles or something like that. But no, you should go very slowly. Go slowly. 4 centimeter per second is the speed. Learn it. Okay, I'm not sure how many of you have seen that doing ultrasound in case of babies, like pregnant ladies. So in that case also, you see, do they do like this? Do they do like this? They don't do like this, right? They do it very nicely, softly. They go around the right? Why? Because if you do the head slowly, it works. If you do like this, it will not work. I'm telling you, it is not of any use. Therapists also don't use many a times school, and then of course patients have that same impression. Okay, so make sure that anybody feeling discomfort or like decreasing output intensity, you should reduce it. Now immersion technique, I'll tell you what, immersion technique is wonderful thing. Go, suppose like irregular areas, like you want to do it somewhere in deltoid ligament, or you want to use for TA, but your ultrasound head is not fitting, because we always say ultrasound head should not be in the air, right? What are you going to do? Take the ankle well placed in the water. Take your ultrasound head, switch on the machine, keep the ultrasound head and this like a skin surface at distance of 1 centimeter. Use it, it works very well. But if you start formation of bubbles more, reduce it. Okay. Bladder method. Many people they use this pad method, especially in foreign countries. A mass of conductive gel like commercial pad is nowadays available. Confirms the treatment area. Use this pad, not a problem.
So you said the immersion technique, but how it will be like for deltoid? How will do?
I said deltoid ligament.
It's in the ankle.
Oh, deltoid ligament. Okay,
Yeah,
okay,
yeah.
okay. Okay, sorry, sir.
And it's okay, absolutely okay. Absolutely okay. Contraindications I have listed here. Please go through that. 100% duty cycles are not supposed to be for the acute injuries. Other parts also you can just go through that. You know also precautions. Yeah, precautions I would like to let you know. These precautions like sometimes symptoms may increase after doing this, but you don't be worried, because this is how the treatment works in ultrasound. Initially it may increase. Use caution when applying ultrasound, especially after laminectomy. Use ultrasound over the metal implants is not contraindicated. Keep the sound heads moving and bit away. Use caution when applying ultrasound over the epiphyseal plates of growing bone. Okay, this is how applied formulation is. Phonophoresis, you would have heard of phonophoresis, using drugs along with the ultrasound pathways through stratum corneum, transfollicular, through sweat glands. Advantages: it avoids risk and inconvenience of IV therapy, then bypass liver in terms of elimination, less chance of overdose and underdose, allow easy termination, permit both local and systemic treatment effects. So here, adequate quantity of drug rubbed into the skin over the target area. Same gel mixed with the standard ultrasound gel placed over transducer head as coupling medium. Ultrasound is placed as a direct coupling method, and then standard intensity go for 1 to 2 watt per square centimeter depending upon the condition. Standard duration is 5 to 10 minutes. Lower ultrasound frequency and pulses lead to deeper penetration. This you keep in the mind. Now, phonophoretic effect, I have given like which kind of chemicals you can use. Of course, you should take permission of your physician, and you should avoid the contraindication or reactions too. Dosage of ultrasound, this is something very, very important part. I have summarized it quite compact, but I will explain you whenever you want. To use for the initial symptoms, 0.25 to 0.5 watt per square centimeter for maximum up to 3 minutes. Progression of dose is not needed if improvement is seen. Okay. If not seen, then increase dose up to 0.8 watt per square centimeter with increased time of 4 to 5 minutes. Okay, not more than that for acute condition. Aggravation is not always bad, as it indicates the tissue repair. Pulse ratio of 1:7 for very, very acute, and for 1:1 for less acute. Suppose somebody has a ankle sprain, he came to you. If you want to use the ultrasound, what are you doing basically? I mean, most of the therapists I have seen, you may not be doing that, but most of the therapists I have seen using the intensity of somewhere between 1.4, 1.6, 1.7 watt per square centimeter for 7 to 8 minutes. That's how we are doing right since our college time. Not good. Just use up to 3 minutes, 0.25 to 0.5 watt per square centimeter for initially. Maybe you can use 3 times in a day. That's different thing, but don't use more than this for at least initially 1 day or 2 days. Okay, and take the pulse ratio of 1:7. Don't take it more than that. 1:7, 1:8. If it is applicable to your machine, to 1:8 also could be there. You use that. Or if it is not there, at least 1:4. But don't go for 1:1 or 1:2. But when the days pass, then you can go for 1:2 or 1:1. I'll come to that.
So how
It
do you
can,
differentiate between the benefits between such a large pulse and minimizing the pulse effects? I mean, like you said, we start with like 1:8 or 1:7, then wean it off to 1:1, and then maybe continuous.
okay.
How is it? And yes, please, sir.
Complete your question.
And again, no, we'll finish this, sir.
Well, if you remember in the first hour of my, first half hour of my lecture, we classified ultrasound is a mechanical device, right? Mechanical device, right?
Yes.
Rather than anything else. So here there is a push of the wave which works removal of pancreating substance or whatever it is, whatever theory says that. So here in acute condition, do you expect, ma'am, giving the more push? No, right? We have to give very limited push of ultrasonic wave so that the healing occurs. Clear? So initially, mechanically, we don't push our injured tissue more than 1:4 in general. But when the time passes, when it start healing, when it start healing, then we can go for 1:2, 1:1, but don't go for continuous at least till 10 days of treatment. Now, you can go. Many people go 1:1 initially for 1 day they go, but pain doesn't reduce. Pain doesn't reduce because by doing so, we are damaging the tissue. How are we damaging the tissue? That's how we learned earlier. The absorption coefficient. Got my point? Are you getting? Absorption coefficient. If I'm doing for the deltoid ligament, are you getting, ma'am? If I'm doing for the deltoid ligament, if I'm using 1:1, absorption coefficient means absorbing more shock will be much more in 1:1 rather than 1:4 or 1:7 or 1:8. Is it okay? This much is clear. So initially we use less shock so that the healing happens. Okay, and it doesn't increase the pain. Is it okay? Now I understood.
Yes, sir.
Yeah. So now if it is a chronic condition, when do you say chronic? Pulsed or continuous, both you can use. If you come to me, generally you see my practice, I don't usually use continuous because I know continuous doesn't work like pulse and it hurts continuously. So 2 watt per square centimeter is for warmth. More than that, it will go for warmth in general for most of the machines. But again, many companies, they prepare their machine in such a way that it doesn't give the heating effect. Okay. Initially, a low dose is given like 0.8. Even for the chronic, don't go for more than 1 initially for few days or for a few sessions and more than 4 minutes. I have seen people giving ultrasound for 15 minutes. I'm telling you, it is the damaging of the tissues. It is damaging of the tissues. Gradual increase in the dose in case of treatment if it is not effective. So increase the dose means increase the timing as well as increase the watt per square centimeter. This is how you should decide the dose. Start with very minimal in time as well as the intensity, what you say, pulse as well as the intensity. All three factors should be minimal. Slowly you go for that. If you want, you can make a chart in the patient prescription or in your diary. In that, what happened in that chart, one will be the intensity, another will be the timing, and third will be the pulse. You can decide this is how I will go. Okay, and you see according to this plan, if you go, you will see the benefit. Don't worry if you are giving only for 3 minutes. You have done your duty perfectly. If you are doing for 7 minutes, it does not mean that you are doing your duty better. No, you are damaging it.
So then how do we decide about the equipment we buy? That you said few machines generate a lot of heat and few machines are designed wherein they should not generate heat.
No, I'm not saying a lot of it. I said that few machines they have designed in such a way that it doesn't give you more than 2.2 watt per centimeter square. You can check a lot of machines. Okay, there are some machines which gives you even 3.7 also. 3.1 I have seen. Even with me, there is some machine which gives 3.1, 3.2 up to that. So the moment I increase
Yes.
more than 2.2, if I give anybody continuous, it will start heating.
Definitely. So is it a good sign or a bad sign, sir?
No, it depends upon what do you use. Suppose I am coming with a deltoid ligament injury, I'm sure that you will never give me the heating effect, isn't it? Or will you?
No, it's only for healing. It's not for.
I'm coming
Yes.
just with the sport injury. You will never give, right? You will give me 1:4 or 1:8
When
just
it is
for 2-3 minutes.
acute,
You want my
definitely the pulsed.
yes. That's what I'm saying you. Yes, if it is a very like old injury or the kind of elbow stiffness is not happening, that place you want to increase the heat. Because these, suppose this bicep tendon has got bit tight, so very well this tendon has more collagen content, so definitely it needs more heat. Okay, and then you see content of the collagen or the composition of the particular tissue what you want to do plays very important role. Okay, uh, the collagen content you have to see in the particular patient, like what are you using? Are you using for the ligament? Then of course even with the two it will be very good result. Okay, why? Because more collagen means more absorption coefficient of ultrasound. So I told you, if you see the basics, you will be able to design your dose very properly. So I always say my whoever works with me, my colleagues, make a kind of chart. Okay, for 8 days this patient will come, this is how I will progress my ultrasound part. Okay, good for you. It won't increase the pain. Otherwise, I have seen people getting more pain after doing the ultrasound effect. It's anyway, it is a good sign of healing, that I agree, but dose also is getting more, so reduce the dose. Now we have come to the.
So what is your comment on that heating, sir? What is your comment on that heating of the head? So should it get heated or should it not get heated?
Okay, that's what I'm saying you. It depends upon the condition you choose. Somebody has come to you, say for example with the tightness of let us take example of 2 years old uh, frozen shoulder. Okay,
No, I
and
understood, sir. I understood. When you want, kind of stretching
lengthening of
effect
tissue.
or,
Yes, yes, yes.
soothing. Yes. So you go for, high intensity and stuff wherein the heat is generated. So is it okay for the ultrasonic head to generate heat? So
Yeah,
is
of
it
course.
not of harm?
No,
Okay.
it's not to
Okay.
harm. No, it's not to harm. Only thing that you should not use the
Because
heating
many
effect
a
for the
times
acute
I
injury.
have observed that in my machine. So by the time I clean the ultrasonic head, I feel the heat on my palm. So
This is true. It happens. There's nothing wrong. Heating effect
okay,
could be. And
okay.
then do one thing. If your machine is getting heated, please check it up. Many a times it
Not
is a
the
problem of the
machine,
chemical
sir. It's the ultrasound head.
head.
When I
Ha.
go for
It.
phonophoresis, so
Yes.
that's when
Yes. I'll tell you why it happens. And then you would have observed that it actually gets stuck after doing the 2-3 minutes of treatment. If you're doing phonophoresis, means it's not very smooth to run, right? You would have observed this also. If
no,
you have not, just
it's
observe this.
fine.
Within 3 minutes it will not be able to go, it will be bit stick, and then you are able to move very slow. But after 5 or 6 minutes you'll see that like some kind of oil has come and then it start moving better, like that happens. You observe this all happens because most of the times there is a green in the skin. I'm not saying that there is a dirty skin, but there is a dust and greens because of sweat and everything on the skin. So you use one thing like take a sanitizer, apply and clean that, or maybe spirit. Just clean that surface you are going to do ultrasound. Okay, and then you go with that. Mix the gel with your what we say phosphoretic agent, whatever you're using, and then you do that. I'm sure that heating part will reduce that.
Okay. So
Okay,
I won't
because
use the gel
greens also
because
play
in
well.
the articles I've read that more than any diclofenac gels, it's better for the spray. So the absorption is better. So I usually go
If
for
it
the
is a
spray.
spray, I'm telling you it will burn more. I'll tell you reason behind that,
Yes,
ma'am.
sir.
The thing is, most of these spray has a menthol. Okay,
Yes,
more
yes.
content of menthol. Okay, so it makes your head heat, nothing else. It may
Okay.
make itchy also the patient skin. Okay,
Okay.
uh, you can use gel based any ointment. Sorry, gel you can use. You should not use cream. It will work bad for your machine. If you are forced to use cream, you have no other option, please use mix with the gel. Okay, because gel is
Okay.
formulated, you know, there is a difference between gel, cream, those chemistry. If you see, there is a difference. So suspended particles in the gel which works very well with the phosphorescence, because you know ultrasound head has a limit. It can't push everything inside. Cream has more concentration, the base is different. You can apply
So when
iodex,
we are
normal
using the
cream, and
spray,
then
we are exerting the ultrasound head more. So we are we damaging the head, sir, or nothing like
no,
that?
no, 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 you're not exactly. Actually in the spray, I would say that if you are not using with the gel, it will heat up more. That's what I told you, because it has a menthol, it has capsaicin. You know, capsaicin burns like anything, and of course,
Yes,
it
sir. Yes.
heat up the ultrasound head. So what you do, I would always suggest you that you mix up with the gel if you are using the spray, okay, or the
Of
cream.
course, sir.
But if you
First,
are
I
using,
apply the gel. Then, with the machine off, I mix the spray and the gel. Then I turn on the machine and then start it.
that way you can go ahead, no problem. That way you can go ahead. If you use
So it
normal
is
gel,
okay for the ultrasonic head to be
yeah, no
heated.
problem, not at all, not at all a problem.
Okay, sir. Okay. Okay.
Because as long
Clear,
as
sir.
you are,
Clear.
yeah, as long as you are using your like you know, like moving your machine is not going to get damaged. I told you, there is something called standing wave. The wave goes and comes back,
Longitudinal
right?
waves. Yes, sir.
Yeah, yeah, longitudinal. So wave goes and comes back. So if you keep your machine static one place, that time it can definitely heat up and damage your tissue as well as the machine too. So that makes the hotspot. We say that hotspot that may. But if you keep moving, that hotspot doesn't come. So even in the baby's case, you'll see that during ultrasound, they never keep at one place. They'll try to move slowly so that they can see in the screen the babies, right? You got my point?
Yes.
Yeah,
Yes, sir.
that
Yes,
that
sir.
that is very, very
So
important.
one last
Yeah.
with the ultrasound. So I'm usually a very much evidence-based practice. I keep I keep trying to be updated. So with this Epsom salt, so they say you can always go with this Epsom salt for reducing the inflammation and stuff.
Yes.
So when we ask, say when you gave the example of deltoid ligament also, so
Yeah,
we
yeah, yeah.
usually
Yes.
ask them to immerse the leg in the water and then we go for ultrasound. I got this Epsom salt from one of the chemical factories. Then I tried to mix it with a gel, but to my amusement, the gel actually melted. It became water. The ultrasound gel
You should
became
never
water.
mix up with
So
the
can
gel,
we
ma'am. That is
add the Epsom?
salt in the water. Yes. Yes.
Yes, yes.
Yes. You can
So
definitely use
when
the
we ask
Epsom
them
salt
to
with the
immerse,
water and then use your ultrasound.
right, sir.
You are not supposed to mix
That's
up with
what
the
was my
gel.
question.
Never ever mix with the
No,
gel.
it
It will be
the ultrasonic gel got melted anyways.
Epsom salt is really good. I mean, right, since in India at least, right, since centuries they are using. Okay, and one of the company had given me as a compliment also, and of course I used with it with the essential oil, so definitely it did not burn, but it was really good. So Epsom salt is definitely any day you can use for the heel pain. Basically, it's really good, no doubt. I actually advocate that. Yes, it is. It is good. You can
But
use that.
we cannot use the Epsom salt for any other area, no sir, except the extremities. Say for the frozen
Except the
shoulder,
extremities.
we
No,
cannot.
sorry, you can't. You can't. Even for the
There's no
shoulder, hip, and all,
possibility.
you can't do it. No, you can't.
Okay,
There is
sir.
a limit to
Okay.
every
Thank
device,
you,
right?
sir.
That is the reason of
True, sir.
we keep inventing. So of course we are a little lagging behind, but I'll let you know today the beautiful device PEMF later. Okay, so now we'll talk about therapeutic currents, a big chapter. I want again break. I don't know how many of you want to get into break. So if you want to get into break, this will be the last break I can give you for 5 minutes. Let me know. Anybody wants to get into the break, I'll break. Otherwise, we'll continue because we are lagging behind time. A lot of content we have finished. A lot more has to.
We'll continue, sir.
Yeah, fine. Thank you. Therapeutic currents. You see, therapeutic currents. I have given the basic, like a basic idea about the current, how it goes. You can go through the basic electricity like ions, electric potential, electron, electric current, ampere, coulomb, volt, everything. So ions, nothing, positively or negatively charged particle. Electrical potential, like difference between the charged particles at higher and lower potential. But electron, fundamental particles of matter possessing very small mass and negative charge. Electric current, the net movement of electrons along a conducting medium. Ampere, measuring rate of electrical current. Coulomb, Coulomb, number of electrons flowing in a current. Volt, the electromotive force that must be applied to produce a movement of electrons. Measurement of electrical power. Voltage, the force resulting from accumulation of electrons at one point in an electrical circuit, usually corresponding to a deficit of electrons at another point in the circuit. Conductance, a term defines the ease with which the current flows in a conducting medium. I mean to say the conductor that permits the free movement, like steel, iron, anything. Insulator, in the body like fat, outside like plastic. Materials that resist the current flow, it doesn't permit resistance. All electrical impedance, same thing, opposition of the electrical flow in a conducting material. Ohm, measurement of resistance. Ohm's law, you know, is V is equal to I is equal to V by R, very popular. What is a measurement of electrical power? Watt is equal to volt into ampere. Electrotherapeutic devices generate three different types of current that, when introduced into biological tissues, are capable of producing specific physiological changes. So three type of current are like monophasic, what you say the direct current, also referred as galvanic, has an uninterrupted and unidirectional flow of currents. Biphasic or alternating current. Pulsating, usually contain three or more pulses in a group and may be unidirectional or bidirectional. These group of pulses are interrupted for short periods of time. All therapeutic electrical generators, regardless of whether they deliver biphasic, monophasic, or pulsatile currents through electrodes attached to the skin. Okay, all three. So I have given a very small overview of this transcutaneous electrical nerve stimulator to stimulate the peripheral nerves. NMES, what you say, the muscle stimulator for stimulating muscle. Microcurrent is generally for the tissue healing. Okay, low intensity stimulator like the same like a microcurrent, and then frequency. If you talk about number of cycles per second, waveform, the term waveform indicates a graphical representation of shape, direction, amplitude, duration, and pulse frequency of electrical current the electrotherapeutic devices produced, displayed by oscilloscope. What you say that cathode ray oscilloscope, CRO, and then pulse, an individual waveform. Phase, a pulse may contain one or more phases, which is portion of pulse that arises in one direction, either above or below the baseline for some period of time. DC is unidirectional, and this is what you call the monophasic. And then of course AC, which is the bidirectional, produces waveform that have two separate phases during each individual cycle. Cycle we say applies to biphasic, and pulse applies to monophasic. So cyclic, what we say, cycle is for biphasic, and pulse we say for monophasic. You'll get clear in the images, and then I'll tell you the calculation also, very easy. Waveform shapes like sinusoidal, rectangular, square, spiked. Biphasic waveforms may be symmetrical, having same shape, size, or each waveform in both direction, or asymmetrical, may have balanced or unbalanced. One phase may have more charge than other. So phase duration is pulsatile waveforms get conduct as series of pulse of short duration and may be either monophasic or biphasic. You can see amplitude, you know very well, of each pulse reflects intensity of current, maximum being tip or highest point of each pulse. Wait, don't get bored here. I'll go to the Just a minute. Okay. Just a minute. I'll go first to the. Yeah, so my observation is personally is like spike waveforms have better excitability of nerve tissues. More rapid the increase in amplitude or the rate of rise, the greater current's ability to excite nervous tissues. Combining high peak with short phase duration is comfortable current for stimulating sensory, motor, and pen fibers. Most direct current generator twin peak spike pulse of short duration 170 microsecond we say, and high amplitude like 500 volts. Sine waves are gradual increase and decrease in the amplitude for biphasic, monophasic, and pulsatile currents. Okay, so pulse duration, you know very well, duration of each pulse is indicated by length of time current is flowing in one cycle. Pulse frequency, number of pulses or cycles per second. I have given, yeah, this is my own view. You know, current have been clinically leveled as low, medium, and high frequency, and a great deal of misunderstanding exists over how have been they classified. Generally, all stimulating current are low frequency and deliver 1 to several hundred pulse per second. Listen very carefully. This is my own observation. I have actually, of course, I have got help from a book also, but recently, a number of so-called medium frequency currents have been developed that have frequency of 2005 to 10,000 pulse per second. So-called medium frequency pulses are in reality of group of pulses combined as bursts that range in frequency from 1 to 200 pulse per second. So these modulated bursts are capable of producing a physiologically effective frequency of stimulation only in this 1 to 200 uh, pulse per second range, owing to the limitation of absolute refractive period of the nerve cell membrane. Therefore, many claims of equipment manufacturers relative to medium frequency currents must be inaccurate. The physiologic response to various waveforms depend upon large extent of current modulation. Okay, so modulation refers to any alteration in amplitude, frequency, duration, or frequency, all these four, or any of these four of the current during a series of pulse or cycles. So type of current modulation could be continuous, burst, beat, or ramping. Okay, I've given the detail about it. You can just go through this electrical circuit. You know very well about the circuit, the path of which current generating source through which various components back to the generating source. So series circuit, parallel circuit, two types of you have. Generally in your practice it is not there. And then I have given the principles. So these principles I have just a sec. Principles I have made it very brief. You can just go through this, like effect of electric charge on tissues in general terms, which depends upon the rate of charge change of electrical pulse. So if there is no change, only a slow change, or maybe a very slow change, the current is unidirectional. There will be a steady flow of ions into the or within the tissues, causing chemical changes at electrode tissue junction. If rate of change is somewhat faster, pulse has long duration, ionic balance across the excitable membrane is distributed, stimulating nerves and muscles. If current is unidirectional, it will also lead to chemical changes as above, but if current is bidirectional, then any change in one direction will be cancelled by other. So this is the principle. I'm telling you, it doesn't happen in reality. Reason behind all the minerals. If the rate of change is very fast, there is insufficient time of transmembrane excitation to occur, so that much larger currents can be employed, can lead to significant heating, basis for dithermy. So this is how the dithermy basis is there. There is a rate of change is very fast. Frequency, choosing appropriate treatment parameters. How do you choose frequency? Okay, I have given this particular thing. How do you do that? Summation of contraction, everything. I'll show you. Tension developed. Yeah, just a minute. Yeah, frequency, it can determine the type of muscle contraction elicited, the amount of shortening of the muscle fiber, and amount of recovery allowed the muscle fiber are a function of frequency. Okay, so mechanical shortening of single muscle fiber response can be influenced by stimulating again as soon as the tissue membrane repolarizes. You know very well the repolarization and depolarization. So before any muscle membrane receives a second stimulus causes increased mechanical shortening of muscle fiber. This process of summation is called summation of contraction. As the number of twitch contraction increases, the twitch responses can be distinguished and keratinization of the fiber is reached. tension is developed by a muscle fiber in tetany is much greater than tension from the twitch contraction. This you should keep in the mind, but majority of you know about it. And general high frequency current is used to produce an increase in muscle contraction. A lower frequency is used for muscle pumping or edema reduction. Okay, tetany muscle condition caused by hyperexcitability can cause cramps and spasms, so be careful. Duration part, how do you choose the duration? More nerve fibers can be stimulated by same intensity of current by increasing the length of time. So intensity, how do you choose? Raising intensity causes a reach of current to deeper tissues. Depolarization of additional nerve fiber is accomplished by two methods, like higher threshold fibers within range of stimulus that could be depolarized by high intensity stimulus, and fibers with same threshold but deeper in structure are depolarized by deeper spread of current. So intensity, it all depends upon how much your patient can take. But in case of paraplegia and other things, you should be knowing how much are you giving, because you have two things to do. Either you should go for the higher threshold that you have maintained, and then of course it should not produce the heat. And then of course you like how deep you have to concern with the muscle, that also depends upon the choosing of current as well as the choosing of the timing. That is how you can go for the intensity part. Either you can keep it as a constant, which has worked, or you can keep increasing if you are seeing the benefit. Polarity, okay, anode, cathode. Then you have a monophagic current. Both electrodes can be designed, and for duration of treatment will provide the polar effect. Polar effect can be thought in terms of three characteristics, like chemical effects, ease of excitation, and direction of current flow. Direction of current flow, I don't think it is well understood. Chemical effects, of course, iontophoresis we are going to see after some time. And ease of excitation of tissue, the polarity of active electrode usually should be negative. And when the desired result is a muscle contraction, because of greater muscle contraction, because of greater facility for the membrane of depolarization at negative pole, that you have to understand, or you have to fix according to your choice. Where are you going to excite the muscle? Either it's a nerve, or it's a muscle, or it's a pain, or it's a purely muscle you are going to excite. So electrode placement, you know very well, right from vector to crisscross to quadripolar to bipolar to all sort of thing you can do it. I have given the various condition also where you can use it, like it may be on and around the painful area, it may be placed over the dermatome, myotome, scleroderm of painful area, it may be close to spinal cord, don't worry, that innervates the painful area, it may be kept over superficial vascular areas, it can be kept over acupuncture trigger point location. Combination of above guidelines, monopolar, bipolar, quadripolar, crisscross, vector position, everything you can choose. Then physiologic effects I have given on the nerve, on the muscle, that we will understand again with the figure. Extent duration curve, one of the most important thing, especially for the research people. Graphic representation of threshold for depolarization of a particular nerve fiber. Hands-on activity, you can go with the hands-on activity. Of course, when we will be meeting up for any physical event, we'll go for this. Rio base is the specific identity of intensity of the current necessary to cause an observable tissue response given a current duration. But you know, chronic psi is the duration of time necessary to cause observable tissue excitation given current intensity of 2 times Rio basic current. So that is how the Rio base and intensity get differs. Indication and contradiction, I think I have missed this page to type. I'll try to type and send you. Treatment protocols. Now the treatment protocols start. So from here, you should be more careful about what I wanted to say. Everybody knows about current, about machines, about the placement, but how do we use it? That is how the whole the whole class of today is about, right? So which condition, how do you use it? I mean, which kind of parameters you use it? Okay, let us talk about denervated muscle. How do we do that? Choose the current with asymmetric biphasic waveform, okay, and pulse duration of 1 millisecond for initial 2 weeks. After 2 weeks, either an interrupted square wave direct current, a progressive exponential wave direct current, each with long pulse duration of 10 millisecond, or a sine wave AC, what you say, the alternating current with a frequency of less than 10 hertz will produce a twitch contraction. Current waveforms should have a pulse duration equal to or greater than chronic psi of denervated muscles. Amplitude must be big enough to stimulate the denervated muscle with a prolonged chronic psi while producing moderately strong muscle contraction. Dear participants, don't get confused. I'm coming to the real part. This is something I have given the protocol, but I'll decide which current is for what, then it will be easy for you. Okay, you can go for the 3 to 6 second kind of pause, or 1:4. You can select either a monopolar or bipolar electrode setup can be used. Stimulation should begin immediately following the denervation using the 3 sessions per day. I'm telling you, minimum 3 sessions per day. If it is a case of, say, for example, neurotomesis, 3 times per day is needed, involving 3 sets of between 5 and 20 repetitions that can be varied according to the fatigability of muscles. You can't be keep giving the contractions. Contractions need to create muscle tension, so joints may be fixed, or isotonic contraction for end range position may be needed. Muscle re-education, how do you choose that? Current intensity, of course, must be adequate for like comfortable to the patient. Pulse per duration should be somewhere between 300 to 600 microseconds. Frequency maybe between 35 to 55 pulse per second. That is how you go for the Faraday current, right? I have given the difference between Faraday and galvanic and how do you choose that. On and off cycle, on time for 2 to 3 seconds, and off time depends upon the patient's preference, but like 1:1 or 1:5. Interrupted or surge current must be used. High voltage pulsed or medium frequency biphasic current may be the most effective. Total treatment time should not be more than 15 minutes. Patient must be taught voluntary contraction along with the current induced contractions. Edema reduction. For edema reduction, of course, 300 to 600, you can go for the pulse duration current, 35 to 50 hertz. Again, you can go for, you would have heard this Faradism under pressure, that you can go with 35 to 50 hertz. Interrupted or surge current, as I told you. Interrupted Faradic is always, the surge Faradic is always good in this case. On and off time should be about 5 to 10 seconds each. And elevation of parts needed to treat. Okay, like suppose edema, I'm treating for the pedal edema, I mean the edema in the leg, then definitely it should be at 45-degree height and I mean inclination, and the patient should be instructed to allow muscle contraction. Active range of motion is needed if it is possible by the patient. Treatment time not more than 30 minutes. High voltage pulsatile medium frequency biphasic current may be the most effective. Okay, fine. Here you can use even the IFT also. If you have any question, I'll discuss later. Use this process in additional of cryotherapy. If you can use cryotherapy, even better. Atrophy reduction. What do you do for atrophy reduction? Here, current intensity must be, of course, incompatible with the patient, but it has to be increased during the treatment as same sensory accommodation takes place. Okay. Now, since you are using for the atrophy reduction, the contractions should be capable of moving the limb through anti-gravity range of achieving 25% or more of normal maximal voluntary isometric contraction, MVIC, that we say as a torque for the muscle. So maximal voluntary isometric contraction. Okay, at least 25% of that it should be able to match. Okay, that contraction we want from the patient. So pulse duration, again the same Faraday current you can go for 300 to 600 microsecond, and what do we say? Yeah, you can go for the galvanic also. Yeah, you can go. Faradic is always good, and on time is like 6 to 15 seconds. Off time should be given 1 minute because a lot of lactic acid would have formed. Now, some resistance to muscle either by gravity or fixing some weights so that isometric contraction can occur. Treatment time is 20 minutes, 2 to 3 sets of 10 contractions, not more than that because it will tire. Prefer high voltage or medium frequency current. You can use even the IFT. Muscle strengthening, of course, current intensity should be high enough to make the muscle develop 60% of torque developed in MVIC. What is MVIC? Maximal voluntary isometric contraction. Pulse duration, again the same. Pulse frequency 70 to 85 pulse per second. Surged current you can use. Okay, on time is 10 to 15 seconds. Off time is 50 seconds to 2 minutes. Resistance should be applied by immobilizing the limb. Ensure 25% of MBIC torque. Greater torque, better the result. Treatment time 10, minimum 10 contraction, mimicking 3 sets of 10 contractions each also works. High voltage, medium frequency, Russian currents here are the best to choose. 2500 hertz, 50 hertz modulated, 10-second work and 50-second off period for 10 minutes. Works very well. Okay, just 10 repetitions of Russian current set in that way. Range of motion generally with the current is again like matter of research, but yeah, I have selected the best of them. So pulse duration, again the same. Pulse frequency you can go for the like below 100 pulse per second. So interrupted or surge current must be used. On time is 15 to 20 seconds. Off time maybe the same or little greater. Doesn't make more difference. Stimulated muscle groups should be antagonist. Stimulated muscle groups should be antagonist to joint contracture, and patient position must be adopted in such a way that joint will be moved to the limits available to the range of motion. Okay, it has been proved by the research. So patient is passive in this treatment and doesn't work with the electrical contraction. Treatment time, you can go for the 90 minutes, like 3 sessions per day, so about 30 minutes each. High voltage or Russian current is a very good choice in this case. Okay, conventional TENS. This is what is what we say the asymmetric biphasic current. Pulse duration, of course, up to 150 microsecond is good enough. Pulse frequency, I say people earlier it was till 100 hertz, but I say now up to the 300 hertz machine also is there. Asymmetric biphasic waveform is already there. On time is continuous mode. Treat time is 30 minutes. Useful for pen. Portable units are better for 24 hours pen control. After the thoracoabdominal incision, or sorry, the surgery or anything, what kind of TENS has to be applied? I'll type it and send to you separately from this manual. Okay, because somebody's told me initially that they want to know about it, so I will send according to the even with the picture and that the 2 or 3 page content. So low frequency or motor level TENS, we say like a pulse duration up to 600 microsecond, not more than that again, and 20 hertz is a good enough. On time 30 seconds to 1 minute. Okay, and then you can use on the, as I told you, motor point, acupuncture, and trigger point. Treatment time not more than 30 minutes. Noxus level TENS, you can go for higher pulse duration but lesser pulse frequency. You'll get excellent result. High volt pulse current must be used on time 30 to 45 seconds. Stimulation over exactly over trigger or acupressure point. High volt pulsatile currents or a low frequency high intensity machine is always better for this. Microcurrent, this you must understand. Microcurrent we are using for analgesia, fracture healing, wound healing, ligament and tendon healing. Okay, but many of us, we don't even know microcurrent should we use or not. Okay, many of the 10 separators, they have this installed microcurrent. Please use it. What is that? Here intensity is limited already up to 1 milliampere. You can't increase more than that, and it can generate monophasic to biphasic square waveform up to just 50 hertz. Pulse duration is up to 500 millisecond again. So treatment protocols of microcurrent is your wound healing, tissue healing, as I told you. So current intensity you see here. Okay, so don't confuse with the microampere with the milliampere. Okay, I have given the 1 milliampere is the most for that 1 MA. Here I have written is 1 mu A. Oh, sorry, 200 to 400 mu A. So don't get confused. Long pulse duration or continuous uninterrupted battery powered is better one. You have machines, beautiful machines you have. Uh, Maximum pulse frequency uh, and monophasic is better than biphasic any day, and 2 hours followed by 4 hours. Long treatment is needed here. Give machine to the patients, it will be better. Negative electrode in wound area for 3 days. Positive electrode should be positioned 25 centimeter proximal to wound. After 3 days, polarity is reversed and positive to be kept in wound area. If infection is not reducing, then negative electrode is to be left in wound area till infections are not evident. If wound size decreases, plateau, then return to negative electrode to wound area for 3 days. Fracture healing, again, not much evidence, but still I have tried to select it with some of the evidences. Of course, you can't increase more than the patient can adjust, and then low frequency up to 10 hertz, and then pulse duration hardly 200 millisecond. For treatment about 3 to 4 times a day. In case of tendon, according to an experiment, 20 microampere cathodic stimulation showed 92% recovery of normal breaking strength at 8 weeks. So this is something very fine, really. Medical galvanism or iontophoresis. The application of continuous low voltage monophasic current causes several physiological changes that can be used as therapeutically. I'll tell you treatment protocol like low volt current, current intensity in patient tolerance, continuous monophasic to be used, low voltage monophasic should be used, and then treatment time not more than 50 minutes depending upon the condition. Skin should be unbroken. Equal sized electrodes must be used over gauze that has been soaked in the saline solution and lightly squeezed. here in the some terms are there: ions, positively and negatively charged particle, as you know, ionization, electrophoresis, that is the movement of ion in the solution, and then electrolyte, solution in which the ionic movement occurs, acidic reaction, accumulation of negative ions under the positive pole, and alkaline solution, like accumulation of positive ions under the negative electrodes, that produces the sodium hydroxide. So it will be exactly different than that. This is how the iontophoresis has been explained in terms of DC. How do we set that thing? So you can just go through that. Most of you that know it is there in the manual. Now treatment technique, if we talk about, continuous direct current has to be used up to 5 milliampere. You use treatment duration is not more than 20 minutes in this case. Dose of medication. Dose of medication is generally milliampere minutes, like total drug delivered. If it is like 40, then it is a 4 milliampere current into 10 minutes. That's how you calculate the dose. Electrodes ready to use, disposable, available nowadays. Earlier we had I have used even the metal ones earlier, covered by sponge or towel, backed by the rubber. So I was getting the this one kind of gauze or something, and we were backing it with the our metal electrode. Negative electrodes should be larger than positive. Selecting the appropriate ions. Indications with various ions used, like analgesia, lidocaine, magnesium. These all things I have given. Spasm, what you are using. Ischemia, what do you use. Edema, what you use. I have given a different chemicals. So just one sec. So I have given different chemicals to be used here. I'm sure majority of you know about it. You have a chart here. I have given according to the positive and negative also. Okay, I have given the recommended ions, especially for athletics, and but still uh, I urge you guys to have a talk with the doctors, of course, with you, to use any of these. And apart from that, contraindication like skin sensitivity reaction, sensitivity to aspirin, stomach ulcer, asthma, McCoil. I mean, all these things I have given. Sensitivity to metals, sensitivity to seafood. So, you know, like, again, the same process. Check the contraindication, learn the risk, then you place the, like, make the patient position so well it can be used, and then start using your device. So this is how it is there, and then I'll just tell you. Wait for a moment, please. Okay, I'll break for just 2 minutes. I will find out this traction part also. I don't see in my this one. I'll break for 2 minutes and then come back to you. Okay, in this I have in this I have not been able to. I think I'm not able to search my this one traction details. So let me find out just a sec. Okay, traction details are not here in this particular site, but I am having idea about it. So I will detail it, and I will type it in your PPT, and then I mean the PDF version, and then I'll send to you definitely. Traction is like one of the device where it is widely used, especially in case of spine. cervical as well as the lumbar. So here in my this one in view, what you need to learn more about the traction is what kind of, I mean, the various kind of tip. I mean to say, if I ask you, uh, just one sec. Yeah, if I ask you that, how do you use traction? How do you calculate weight? Then what is your answer? Anybody?
So for lumbar, we have a different formula, and cervical, we have a different formula.
Yes.
So
Okay,
we
what is the formula
calculate
for
the.
lumbar?
So for cervical, we use like the body weight divided by 7, and for lumbar, we use like body weight divided by 3 or 4, I guess. 3 or 4, I guess.
Okay, I'll tell you one thing.
But
Earlier,
it is again highly controversial, sir. When it comes to clinicals, we don't even check the body weight, and we just turn on the knob of the traction and we go for it. And
why don't you check body
so,
weight? It can give a lot of effect. I mean,
yes, sir.
it's really very risky if you don't check body weight. It goes quite risky because
So the
what
last
happened?
we used traction was in my BPT days. As I'm a manual therapist in my MPT, we never touched any electromodalities. That's exactly
Okay,
why I came back to this webinar.
okay, fine. Look, what happened earlier days, or maybe you would have seen the machine where there is no separate tables, right? The tables are like continuous. In that case, the weight selection will be different. And in the case of like a detachable table which actually works on the spring or something, here you have a different sort of thing. So all these that matters a lot. Okay, when it is a matter of choosing the weight. So okay, fine, let me tell you, let me give you some of the tips in traction. First of all, anybody who has a problem of atlantoaxial joint issues, I mean it can happen with the rheumatoid arthritis patient also, never ever use it. Reason behind, I'll tell you, it can give a serious consequence. Serious consequence. Reason why it is giving a serious consequence, you know, because patient can die. Patient can die. It is so unstable, patient can die. So we always say people that, just a minute, yeah, we always say people that don't use for RA kind of case. Okay, and then when it is like a muscle spasm, you have a different thing to do. When it is like generally, if it is a traction, you know, as a physio you should know what happens here. Here it pulls the vertebra in longitudinal force, isn't it? So once it is choosing in like a longitudinal force, it makes the nerve fibers, I mean the peripheral nerves, coming out of the what we say, uh, uh, coming out of from the disc, uh, coming out of the spinal cord to the like suppose the L3 is there, that particular nerve. So if it is a problem of L3 L4, so generally with the traction that pulls, that's how it releases the nerve, and the patient find lot of comfort during their just 1 minute. They find lot of comfort during their symptoms, like kind of numbness, kind of anything which is giving them trouble part. So that is how we use the traction basically in terms of just a minute. Yeah, I will send you this only. The thing is like it is having a updated version of this one. So yeah, so that's what I was talking about traction. Okay, Latin word traceo means drawing or pulling apart. Indications, but not limited to nerve root decompression, disc protrusion, what I was talking to, muscle spasm, hypomobility, disc degeneration. Traction can release nerve roots, reduce pain temporarily, and break the chain of pain spasm pain cycle. Spinal traction is a distracting force pulling vertebral surfaces apart through the manual, mechanical, or motorized devices. Pressure from longitudinal ligament stretch helps nucleus pulposus to go back in its place when traction is applied, resulting in increase in the fluid pressure due to decreased disc pressure contributes to the healing of annulus fibrosis. Excessive traction may cause hyperhydration, so never ever use it. It can lead to the it can make your patient more prone to the injury, just like a overfilling of balloon. Sustained traction should be done while treating degenerative sustained traction must be used while treating degenerative disc issues, nerve root compression, and muscle spasm. Intermittent, you can consider when you are treating the facet joint issues or disc protrusion. So cervical traction, if I give some of the tips, when applying intermittent traction, rest period involves reduction of force by 1/3 maximum. A minimum of 15 degree of flexion is needed to open the posterior of cervical spine. This is how the science is. And neutral position traction causes greater separation in only upper part. A flexion of 30 degree directs more force to lower spine. To optimally widen intervertebral space, open IV foramen and open posterior facet articulation, 20 to 25 degree flexion is very much needed. Always start manual traction before device. Keep in the mind, always start manual traction before device. Important to know any pain or difficult areas. If you find any pain or difficult areas, never ever proceed ahead. Always do in the supine line position, never ever do in any other like position. Intermittent cervical traction may be applied for 5 to 10 seconds, followed by very small rest period. At least 10-pound weight is needed to counter gravity, and 25-pound weight is much needed for straightening cervical lordotic curve and earliest separation of posterior vertebral ligaments. Maximum force can be anteriorly C4 to C5 after 25 minutes, posteriorly at C6 to C7. Distraction effect is short-lived. Discontinue in case of nausea, dizziness, or increased pain. As I told you, do vertebral artery test before traction. Midline disc herniation is contraindication, as it can pull spinal cord with it, and person can die also. Patient with rheumatoid arthritis or connective tissue disorder, like they may have atlantoaxial axial insufficiency. I told you earlier, it can dislocate and sudden death might occur. So in this cervical traction, you should care of these things. Lumbar traction. It is a process of applying a stretching force of the lumbar to the lumbar vertebra, simple, through body weight, weights, and other pulleys. So as I told you, load section, you may have two aspects: overcoming friction between the body and bed, and amount of force required to exert an effect on the lumbar spine. So here, what happened, there was a scientist called Judovich who found that traction of 26% of this body weight was required to overcome the friction. So to use the split tabletop with friction-free rollers reduces this to a negligible amount. In its absence, a force in excess of 26% of body weight must be used before any effect can be produced at the lumbar spine. So here also sustained, you can use slightly lower force, and then 10 to 30 minutes, intermittent 30 seconds on, 15 to 30 seconds off, longer on time up to 60 seconds for disc injury, and shorter on time like 15 seconds for facet joint dysfunction. So this you should keep in the mind. Apart from that, I have given these two picture. One is a biomechanical picture. You can see in this split table that there is a force F track, means force of traction. Then there is a stool that 90% has been achieved, and FB is there. And then you can see RP, I think it's the resistance of pelvic. And then RT means resistance of thoracic. Yeah, and then FB is nothing, it's a force vertically it goes, and then FH is something force horizontally it goes. So if we calculate, that is about 18 degree of angle which is achieved. If you go to the previous figure, it is something like with the body tissue, how you see the two vertebrae getting split, and then of course the nerve roots getting released. So once it is released, it gets the free this one. So this is how the class of today, means most of the class of today is like done. So like here on board, we'll be seeing the best of today's version, like the PEMF value, PEMF things, and fine. Here I'm sharing the screen of PEMF device. Just shared within some time. Yeah. So, how many of you have used PEMF?
Can you come again, sir? What is that?
How
What's
many
that
of
device?
you as PEMF device or have seen PEMF? PEMF is nothing. It's a PEMF is pulse electromagnetic frequency. Okay, so of course I have chosen this particular company. The thing is, like, because I have gone through various clinical paper, clinical studies, and they are the FDA approved people, so I have chosen them. Okay, so there are some explanation about Oscar device, and then how the PEMF work. That is how I want you to learn. Okay, PEMF is something, the 0.7 millivolt electrical current at the cell level is naturally maintained. Okay, so these devices are supposed to bring that sort of environment to your basic cell. So suppose there is a pain particle or any of the problem, stiffness, the cells are not working fine, the group of cells in the tissues, right? So in the PEMF tries to bring back to the natural phenomenon. That is how naturally the cells develop. I'm sure now you understood that. Okay, so generally what happened to the injury? We learned in earlier part of our lecture, like the inflammation. What happened? You have 5 things, right? Pains, I mean the dollar, keller, tumor, rubor, or loss of function, isn't it? In inflammation, these things happen. So phases of inflammation, if you see, there are like literally you can actually divide into these things like injury, hemodynamic, sorry, ultrastructural changes, metabolic changes, activation of chemical mediators, hemodynamic changes, permeability changes, leukocyte migration, phagocytis. Okay, so this particular device, I mean the PEMF works differently at different portion of inflammation. Okay, so injury, like physical agents, whatever, ultrastructure changes, eventual breakdown of cell membranes, that's how it happens. Metabolic changes, not reaching enough oxygen there. Okay, activation of chemical mediators, like act like a traffic police. Yeah, but what else? I also, right? Histamine, bradykinin, prostaglandin. Okay, so hemodynamic changes. What you say, homeostasis, right? So permeability changes. So these all are the changes after an inflammation happens, right? At last, phagocytosis. So what happened here? You have this particular device, I mean the PEMF device, it actually, as with inflammation, tissue repairs, it starts, and it actually follows a general process of cellular response, what you say, the auto response. In this response, what happened? It's expansion of phagocytosis, of course. Macrophages scavenge the cellular debris, and the circulatory and lymph systems drain away the liquefied cellular remains, which are mostly small particles of protein. So here, this device particularly work all through these phases. So it's not magic. It's the this is how PEMF works. Magic. This is how PEMF works. So one PEMF device, it actually works through all these phases. Okay, so first phase is something I told you, this cellular response means auto response, isn't it? Auto response. Okay, so after this auto response, what happened? This machine switches for the vascular phase. Okay, PEMF phases for the vascular phase. OSCA AB phase, we say. I mean, so of course, according to the digital terminology they have given, the vascular response is a transient phase during which new capillaries are formed. Okay, these new vessels deliver greater amount of oxygen and nutrients to the wound site. A process called capillary budding is a mechanism at the vascular phase. Collagenization, OSCA they are writing OS and CD phase. It depends upon the machine. But after this phase, this machine turns to the collagenization. It's a process of manufacturing and laying down of collagen. Collagen is a fibrous protein, and main component is what? Main component of ligaments, tendons, cartilages. Firstly, fibroblasts migrate along the strand of fibrin into the wound area, manufacturing strands of collagen which are extruded haphazardly into the wound space. So this will maximize after the 4 to 6 stage. Then it goes to the next phase, the last phase, contraction and restructuring. So contraction and restructuring is the process that causes scar tissue to contract. The capillary arcade collapses and compressed with the surrounding collagen, which accounts for much of the contraction. This is what our thing is. If you leave it, it will become into fibrous. Then the ligament will be tough, right? It will be more painful, right? But if you use this device, what happens? It brings down your natural process and upscale your growth of the patient's problem. So it's not just a pain-killing device. It's a device which brings your patient's impaired tissues into natural healing system. Okay, endothelial cells from the inside lining of vessels. It is like lymph vessels, and then of course heart, and then mitosis is the process where cells separate into duplicated genome into the two identical halves. So these all are the like a fibroblast, and then it goes for it actually goes for the total this one. So this, you can see this technical support is available from the Australia, and then references are a lot, and then it is a FDA approved device. So that's the reason I have chosen it. And then if you want to learn, if those who are in Bangalore can visit personally to my clinic, I can show the device. This device is not a magic. This is how the PEMF works. So if you keep it at place, it's not like 1 minute, it's not like a magic. You need to keep for 90 minutes, and you can do exercises, you can do your other physiotherapy, doesn't matter, but you keep it as 90 minutes. You have a beautiful strap, you strap it, and then you switch on. That's it. It will start working. You work for yourself, it will work for itself. So it brings down your impaired tissue in such a way. Suppose I'm having I am using this device past 1.5 months, and then one lady recently with a what we say frozen shoulder of past 6 months, that pain has reduced. Now I can easily work on her stiffness. That was not possible. That was not possible. I can say you that pain is reduced such a level that I can use more and more exercises for the stiffness. So this is how this device works. It brings down your electrical activity at the cell at the natural level. It brings down more fibrin, more collagen, and then of course improving the circulation. That is how it works. So 90 minutes for 2 times in a day, and do whatever you want. It will be working at this. Sometimes some heat come. That is because of increasing the circulation. So this is how this particular device works. I will send you about this also. Those who are in Bangalore can personally visit my clinic and see this device. So this is how today's session we have come to the.
So what is the cost of this device, sir?
Cost of the device, I think this company, they are charging about 55 to 60,000, but first you learn it. I'm not for that. First you know about it, then only it is possible. I mean, it's not something that you should go blindly about it. So first you know about it, then I will tell you that you should go about it. Okay, cost, they were saying about it. It has a different 3 types. You know that. I mean, if you have asked, then I will tell you. Even they are working very hard for the corona patients to have much and more data, because they have one unit, I mean one type, which works for 3 hours to keep all the different lung area, and it actually reduces the fibrosis. So they have very less papers on that. So even many hospitals, they are trying to have much more paper on this. So once that happens, this will happen in a very proper way. But for pain, stiffness, and this device is really wonderful. I can tell you, in this corona pandemic, it worked really for our team really well, because the patients I can't see, and then of course I can't see suffering the pain too. So I used for 1 or 2 person. I gave them, you use at your home, and then I'll be in the contact with them online, so that I can suggest the exercises. The day when I gave, I'll be checking that, and the moment the pain comes down, they are ready to do most of the exercises, isn't it? So that's how it works. This particular thing has really improved my confidence in physical therapy, and this has been done after the 15 years of continuous research by the team, and then they got the FDA approval. Anyway, I'll send you these details also whenever you want. And the cost they are keeping 55,000, but of course, if you go through our academy, that will be reduced a lot, no doubt. So I have come to the end of the session. So should we have some of the case studies, or if you are ready, then whatever you say.
So if you don't mind, can we go with few of the doubts for the previous slides? I mean, not the new modality what you showed, the basic modalities what we already know,
Yeah, yes,
like
yes, yes.
the
Go, go, go,
TENS,
go ahead, go ahead.
IFT,
I
and all.
want. That's what I'm saying you. That's what I want from you people. Yeah,
So
please.
practically, nowadays, like we have clinics, we have home visits. How it has been is that the IFT costs a lot and TENS is much way cheaper. So the physiotherapists, they buy the TENS and they go for the home visits. And even though there is a prescription of IFT, they go with the TENS. In your opinion, is it really effective, sir, for pain relieving?
Okay,
Because
very,
TENS is
very
a low
practical question
frequency.
and very good question. I really like that question because unless you ask me this question, I will never answer this question. The thing is, uh, because like I don't want to create any confusion among anyone. Okay, so this particular PPT I'll send you. It is updated version. I have done it. Yeah. So TENS and IFT, very good combination.
TENS is a low frequency current and IFT is a medium frequency current. It's like a world of difference.
Okay, as you have asked, I think many of them will have this question in the mind.
Yes, sir.
Let's talk about IFTR. See, uh, there is something called beat frequency. Have you heard of beat
Yes,
frequency?
sir. The clover leaf arrangement of the electrodes, the anode and the cathode, the clover leaf arrangement, where we focus the pain area into the clover leaf arrangement.
Okay. Okay. What is the difference between frequency and intensity in terms of when we apply to the patient? Can you elaborate about it?
Frequency is the number of times
No, I'm not asking definition. Now
the
we are away from those
electrical.
topics. No, don't worry about that. I am just asking. Do
Okay.
you know any the relation between the frequency and intensity? I mean to say, okay, let me explain you only. If there is a more frequency, okay, intensity will be less in general. Okay, in general, I'm telling you, in general. Okay, but when there is a more less frequency, intensity will be more. Okay, in general, this is the basic of the machine I'm telling you. Okay, now come to the TENS. As you told, is a low frequency machine, but I would tell you, as in the this one also you can see what you say that manual you can also see. I don't really bow on the low frequency because nowadays TENS is also up to the 300 hertz, right? What is making the TENS special is, okay, what is making the TENS special is it has effect on the nerves. Clear? Isn't it?
Yes, sir.
It is stimulating the nerve, and that is how it is blocking the pain. Clear about it?
It works on the pain gate theory, activating the collateral.
Exactly.
No,
Exactly.
yes.
Yes, it stimulates the nerve basically, right?
Yes.
Now, if you come to the IFT, what you were saying that medium frequency current, anyway, that I don't agree with that medium frequency type of thing because suppose there is a frequency of 3,800 hertz, one pole, like the black one you have used, right? And the red one is 4,000 hertz. So there is a difference of that will be called as beat frequency, isn't it?
Yes, sir.
Yeah. Okay. So beat frequency is supposed to go inside and to produce the localized effect. Effect will be again the same, the pen gate theory and all those things. But again, the effect is quite localized in that particular thing. I'm talking about the beat frequency. Okay. Now, if you talk about the TENS has a superficial effect compared to the IFT. but IFT has a
Correct, sir.
deeper effect.
Agree.
IFT has a deeper effect. So those who are doing this kind of golmaal, that IFT has been prescribed, TENS has been given, IFT has been should be used, and TENS has been used. So I won't comment on them, but yeah, you should choose your condition. I mean, I'm just asking you now, you will only be able to answer me. I have got a soreness in my, okay, soreness I will not tell. Yeah, fine. Okay, soreness in my lower back during the treadmill. Okay, acute soreness. If there is a current part, I give you only two choice. Either you go for the TENS or you go for the IFT. Which one will you use?
I first ask you about the symptoms. What kind of pain you're having? Are you having some shooting pain, or are you having dull aching pain? So
I told
usually
you,
when we ask
acute
for the
one.
nature of
It's
pain, when
acute
they
one. So
say
it's
dull,
yeah. Yes.
so dull is always referred to the muscle pain.
Yes.
So shooting or sharp pains like pins and needles, it's nerve. So
Yes.
nerve, tense, muscle,
Yes.
IFT.
Clear, right? Now this is how you have to, because you know in due course you learned about, like, of course, yeah, it's excitability part. So spike things, spiking means what you say, that nociceptor pain. So of course it's a pinching kind of pain or sharp pain, pin needling kind of pain. So let us use the TENS. Clear? When it is a dull,
Yes.
aching, large part of muscle is getting into pain, definitely the
Go for IFT.
IFT. Very clear. Okay, now second example. I am having arthritis since 2 years and I have been told to take the current. What are you preferring, TENS or IFT? Knee. I'm talking about knee problem. Osteoarthritis of knee.
Preferably maybe, like, you get the prescription of IFT, but maybe I feel we can go for TENS.
No, IFT would be better in this case. I'll tell you why. Reason is, again, you'll be asking your patients how it is paining. Then he'll be telling you, anyway, the pain remains, but past 3 days I am having more pain, inflammation kind of stuff, right? So in that case, you want to make your current reach deeper, right? If it is that case, you definitely use the IFT in crisscross pattern, isn't it? But when it is a kind of what we say, that the pain is like no normal pain always remains, and you find that medial part is more painful, the muscle is more painful, then localized kind of thing, you can even use the TENS. That's not a problem. But when it is a deeper pain, I always say people to go for the IFT.
IFT.
Okay, now I'll be giving you third example. Suppose I'm having a sciatica. Okay, sciatica, then like sometimes in a year the pain increases, then you will be taking my examination, you found out, yeah, of course I'm having some sciatica case. In that case, what kind of current will you use, IFT or TENS?
It's defaultly TENS. Default, it is TENS.
By default it is TENS, but I have seen people using even IFT.
IFT, it is only for the back area, wherever
Yes,
they are like
that is where
suffering.
the
But
people get
when you're
confused. Okay,
when
because
you're arranging the
yeah,
electrodes throughout the course of the nerve, you have to
nerve,
go
yeah.
for TENS.
Okay, very good. Now, suppose I'm having a problem in the today morning only, I'm telling you the story. Like the person had a problem in the tensor fascial latae, just because of some morning walk problem or something in the muscle issues. Tensor fascial latae, pain was across that. So in that case, I should use what, TENS or IFT?
IFT, because even that fascia lata is covering the muscle itself.
No, here
But
I use TENS.
superficially, it is a fascia.
Yeah,
So you
so I
can go
used
with the
TENS.
superficial modality, which is TENS.
Yeah, that's what I use TENS. So I thought that you are proving me wrong, but I think now I'm correct. So I used TENS of the PWM. I mean the burst kind of TENS. I used for about 20 minutes in less frequency because it was quite superficial. Okay, so if somebody has a piriformis tightness, you got my point, piriformis tightness, and because of that he's getting confused that kind of sciatica kind of pain is coming in the inner and medial thigh. You got my point? You got my point? The fourth case
Yes,
history,
sir.
what I'm talking. In that case, what will you use,
Yes, sir.
IFT or TENS?
Piriformis is a very profound muscle.
Yeah.
So you can go with IFT. Once that muscle is releasing its spasm, automatically the compression on that sciatic nerve will be reduced. So
Okay. But
IFT for the low.
during my experience, what I understood, ma'am, high frequency TENS works better here.
Okay.
Because pain is the prime focus to reduce. And then of course you are doing the cryotherapy and stretching the piriformis muscle. So to reduce the further course of compression of the nerve. Okay, this was the fifth case history. Sixth case history, let us talk about somebody had a lateral thoracotomy incision. Okay, he's anyway correct now. He came out, and but there is always a kind of pain is there in the chest wall. What will you prefer, IFT, TENS, or galvanic? What?
Not IFT, because we do not want to penetrate deep.
Very good.
Neither for the
Here we will be
muscles or
using the
organs.
TENS, right? Here we will be using the high frequency TENS. Reason behind, you only gave the reason. We don't want to go deeper, right? We want to travel somewhere between the chest wall part, right? Isn't it?
Yes.
You gave me the reason. So I'll be using the high frequency TENS maybe for 5 minutes, or if I'm using some 100 hertz TENS, I'll be using for say for example 15 to 20 minutes. Okay, fine. Now seventh case history. In case of abdominal incision, okay, say for example after appendicitis, the person is quite fat and he's getting still pain, not pain but kind of dull. So what will you use, IFT or TENS?
Again, we can go for TENS itself, but
Exactly. Very good.
it's
Very
again,
good. Very good. I'm very happy.
we don't want to penetrate through the organs,
Penetrate
because
through, yes.
abdominal area, it's viscera.
Yes, and then there is no use also because you have fat a lot, right? So we will be using here low frequency TENS, okay, so that it can penetrate up to the abdominal wall. I'm hoping that every participant is learning. So it can go through the abdominal wall easily, and apart from that, we can keep it for about 30 minutes. Clear? Everybody's
Okay,
clear?
sir. So
Yeah.
I'm
So
now
seventh
clear with
already over.
the
Okay.
selection of modality, but now coming to
Yes,
the
that is what
selection
my
of the
concern was.
settings. Yes, sir. Now
Selection of
coming
the
to
settings, if you go through my manual, it is not one day job, right? So selection of the setting is something you have to learn through the over the period of bit time. Because
right, sir.
selection of
My
setting
meaning
is
was
something.
like low frequency or high frequency. So it
Okay.
is like that, sir.
Okay, low frequency.
So how do we go with the selection?
Low frequency. Okay. Okay. So low frequency and high frequency, how do you select? Okay.
Yes, sir.
First of all, I'll tell you, you only gave your answer past many case histories. Anything is superficial, low frequency.
Go with
Anything you
TENS.
want deep,
Yes.
medium frequency. No, wait. Medium frequency like IFT. I mean, in general, I'm telling you, again, it won't be a hard and fast rule. And then any kind of diathermy stuff, go with high frequency. Because there is a fast movement of the ions, isn't it?
Okay.
Got my point?
I'm sorry, I think I have to reframe my question. It is it's about TENS, sir. High intensity TENS or low intensity TENS. I mean high frequency. The settings of the TENS, what I mean is.
Oh, setting of the TENS. Okay, fine.
Yes, sir.
Yeah. Okay, just a minute. Yeah. So setting of the TENS is something. Just one sec. I think it's not there in this. Otherwise, I would have shown you here only. Okay. Say for example, muscle relaxant you want to use for muscle relaxant. Okay. What are you thinking that we should go for the low or high? Let us clear about it first. Of course, we will go for the low frequency, right? Right? Because here the muscle we want to relax through the nerves. Right. You got my point.
Okay.
Okay. So muscle relaxant will be going through the low frequency tense. Okay. And suppose there is a wound healing. Then we want little more frequency of the tense. Something like a microcurrent, okay, up to 50 to 100 hertz. Even for the pain, if it is a pain of dull kind of thing, we will be using the high frequency tense. Okay, if it is a what we say that sharp kind of pain, I'm telling you, if you use high frequency tense, it will not work. It will increase the pain. Got my point?
When do we use the high
So,
frequency, sir?
okay, generally acute, I mean just telling you, acute pain, okay, keep in the mind, acute pain anywhere around 100 hertz you can use it. Okay, even 1 hertz can be used, but depends upon what condition are you using. Okay, now suppose I'm using something like a muscle, what we say, stimulating the muscle, say for example a CP baby. Okay, I mean the about 10 years old CP baby, I mean not baby, of course, CP boy, where the doctor has written to use the TENS. You know why they have written? They have written to stimulate the muscle further, right? In that case you have to use 50 hertz in general. Okay, around the 50 hertz. Chronic pain also with the lower frequency, they get some benefit, but I always say that it depends upon which kind of pain they have. Okay, if they have a pain in a different area, it goes differently. It won't actually work the same for everything. You I mean if you check about possibilities, then you should go to my wait, I will share the screen again, you will come to know. Just one second. I will take you to the basic, then it will be easy for you. Come to this. Okay, now let us talk about this. Okay, here you can see A delta, A beta, C fiber, right? So generally, this kind of pain has to be addressed by pain gate mechanism, as you know. That could be through the A beta fibers, that is the sensory fibers, right?
Which is
So it
proprioception
reduces
and
the,
touch. Yes.
yeah, it reduces the transmission of what? I mean, whatever the stimulus it has found through the from the C fibers through the spinal cord, and hence on the, I mean, what we say on the subcortical areas, the higher centers, right? A beta fibers, it is for, I mean, it gets stimulated always at bit high frequency. Got my point? A beta fibers
Okay.
usually get stimulated at bit higher frequency. Okay, so single frequency, if you want like a hard and fast rule, it won't work for everybody. Okay, now we can actually convert into like a kind of, you know, like a differences. So let us talk about again otherwise A delta fiber. Okay, A delta fiber, even with the low frequency up to 5 hertz, okay, means when we in the spinal cord, which will reduce the activation of your stimulus, and that is how you feel the pain is less. Okay, but again, other possibility, if you talk about, say for example, higher frequency, about 100 plus hertz. Okay, if you keep it as like a burst mode at rate of, say for example, 5 bursts per second. Okay, so it will deliver the pulse. I mean, the 100 hertz it is delivering, so it is activating which fiber? A beta fiber. Simple, right? So, so the pen gate mechanism get activated, and then it will produce the excitation of the even A delta fiber. Okay, and then opioid substance will come easily out. That's how they get the pain relief. Okay, so I'm telling you, these diagrams are very important once you understand which level this particular opioid substance comes. Yeah, this is, you see here. Okay, in general, if you ask me about the condition, I can tell you, yeah, this will work, but we can't have a single frequency for everybody. You got my
How
point?
about the modes, sir? The intermittent and plain. I mean, continuous and intermittent. How do we choose that, sir?
Okay, intermittent, of course, in the acute and subacute case. Continuous is basically for most of the time chronic.
Okay. And as you mentioned during the webinar, you also mentioned that when we are choosing high frequency, we go with low intensity or lower time, and vice versa. Is it applicable for this TENS also, sir? Like when
No,
we are
timing
giving...
I did not know. High frequency and intensity I related, no doubt. Frequency and intensity I definitely related. I did not relate with the timing
Okay,
as
okay.
per se. Okay, timing, if you ask me, I'll tell you that let us tell you very simply, I'm telling you. Okay, intense, what we say that with the burst and all, right? So those kind of things, burst means active, what you say, intense tense. Earlier it was coming in our you can see in our old machines, intense tense. Okay, that you should not use for more than 5 minutes in general. But in general, your high intensity, low frequency, especially for muscle pain and all, if you are using high frequency and low intensity, that we say the like those kind of tense only for 20 minutes or maximum 25 minutes, not more than that. Okay, more than that it won't work also. High intensity and low frequency, what you say that low frequency tense, I mean the low tense, earlier it was said low tense, so that you should
Yes,
not
sir.
use
High
more than
TENS
20
and low
minutes.
TENS.
Yeah,
Yes.
and high tense you can use for high tense, you know, high and low, how did we divide? We divided according to frequency, not intensity. People get confused in this. High tense is means with high frequency, low tense means low frequency. So high frequency tense you can use for little longer period, like 30 minutes. So I told you even that time also that high frequency means it will deliver low intensity, so you can use for longer period. Okay, but low intensity low frequency means it will be having a higher intensity, so you should not use more here. If you talk about the trigger point, if you know, suppose I'm having a trigger point in my back, you can actually apply the electrodes over there, and then you can use the low the low tense, that means the low frequency and high intensity for 20 minutes. So directly on the trigger point you can use it. But in this case, high intensity, the high tense, what you say, the conventional tense also we say that 30 minutes you can use. There the high frequency you can keep on the site of pen. That does not mean necessarily the trigger point. So that is how the overall chooses of type of tense you can do it in general.
Okay, sir. So when we
So
come
it
for
is
this
not always,
IFT,
yeah,
we have this
yeah,
setting called as base. So we were once
yeah.
told that base is something equivalent to the depth what we choose. Is it true, sir? Depth of the treatment area. Is it true, sir?
Depth of treatment area. Base is
Like,
in the base is in the frequency. I mean base, if you see madam, it is a frequency, right? If you see the base and spectrum both, that comes into hertz rather than anything else, so there is no distance into this, isn't it?
okay.
I
So
mean there is
how do
nothing
we
like a
choose the base
centimeter
and
or
spectrum, sir?
okay, how do we choose the base and spectrum? Yeah, I've seen in many of the machines it is there. Just a minute, I'll check the chat box again, I'll tell you. It is not coming. I don't know what is the problem. Okay, I'll stop sharing first. Yeah, so it's not actually the distance. It is something the what we say that frequency measurement. So first of all, let us understand that why do they use this? Okay, so once you understand that why do they use it, then it will be easy to understand. There is something called frequency sweep.
Yes, sir.
Okay, have you heard about the frequency sweep in the like how does that work? I mean,
Sweet.
of course, in one day small seminar
Yes.
is not possible,
Uh,
but still, I'm just asking you, like, have you heard? Look, what happened? No, generally the nerve will accommodate to a normal signal which is coming, like continuously, right? Any nerve, that is something what we say the accommodation. Also, you would have heard it. Then gradually changing frequency we are using for accommodating that for reducing this problem. You got my point, man? Suppose one
yes,
intensity which
sir.
is
We are
coming.
breaking the accommodation.
Yes, now if you understand the sweeping frequency sweep, then you will understand why do we use that spectrum. Okay, so principle of basically
So you're not audible.
machine earlier there was no base and all. Okay, so like a sweeping kind of stuff. Okay, so so top frequencies, let us talk about, say for example 25 hertz. Okay, and some of the machines they are sitting at about 15 hertz. So this sweeping pattern, if you understand, this is much easier than just to break that. We need to make a base. Okay, so that base we create, and after that, on top of that, we choose the spectrum, how much it will be going up and how much it will be coming down, so that the frequencies coming to our body should not get accommodated. Okay, now once you talk about that sweeping pattern, how does it go? It can be, I mean, that much deep I did not go into my ppt, but again, if you have asked, then I'm telling you, it could be more than, like, the waveform. It is like a waveform. It could be triangular, it could be trapezoidal, it could be rectangular.
Square.
Okay,
Yes, sir.
so yeah, so these significant it actually makes a lot of significant difference. I mean, if I tell you that triangular, very well, triangular waveform we are using only for the
Acute.
acute case. Yeah, very good. Then rectangular we are using for the subacute, and then trapezoid we are using for the chronic. If I'm not
Chronic.
wrong, just tell me. Yeah,
Yes.
so
Perfect.
so these machines, they have made it in such a way that very limited, I can tell you that we have this one. So we have generally, I am having some of the machine which is having between 90 to 125 135 hertz, that sweeping like a kind of thing. So I
Spectrum.
do
Yes.
what I yeah, yes, exactly. So I do what, this particular thing, I keep the base at about, say for example 100. Okay, then the sweeping part, I keep the spectrum running up to 130 and then coming back. Okay, so it works in quite a special way. You got my point. It works in quite a special way.
So
uh,
should we arrange that in opposite poles, like spectrum should be high and the base should be low, or is it something like that, or should both
no,
of it be at the higher limits?
no, it's not about high level. It's about that when I studied, I learned that base should be kept at 100, or say for example 90, or maybe about, say for example 60 or 50, whatever. But spectrum should be a bit higher, so that you can see that spectrum will go high, again it will come back. You would have seen that there is a LED also which
Yes, sir.
actually
Yes, sir.
works
The
along that.
symbol,
Yeah,
symbol. It. Yes, symbol.
yeah. If you keep the spectrum, you do one thing, you keep the spectrum less than that, it will not work only. So you're not letting your frequency to go ahead. You got my point. So selection of these kind of
So how do we
like a
decide the base, sir?
okay, base is something you have a permission to decide up to 100 hertz. It depends upon the, again I told you, the area also. So like it depends, how can I tell you, accommodation, it depends upon person to person, isn't it, ma'am? Accommodation cannot be same for every person,
Yes, sir.
right? So say for example, if somebody is
Yes.
well perceived with the high frequency current, that means you can choose it about 100 hertz. If it is somebody is very sensitive and can space about low frequency current, means high intensity, like they're very sensitive, you would have found the many patients who can't take more current just because of fear, not because of they can tolerate or not. In that case, you can choose less. Okay, so I'm very honestly saying that I never learned about this particular thing, how to choose base. But how to choose base never depends upon any condition, that I can tell you very clearly. This is something has been given by the manufacturer to break the accommodation issues. And then yeah, and then when I learned it, I mean through some evidence also, I actually went through 2-3 manufacturers company also, factory also. In that case, they were just saying that you can keep a base at certain thing, and then spectrum you can make it up and down, so that the person will never tell you, okay sir, you can increase, I'm not feeling anything. You can choose, I mean both you can keep similar, and don't tell your I mean don't let your spectrum go up and down. You see, it will they will say that it's actually I'm not feeling anything, sir. You can increase or decrease or whatever. So selection of these wide frequency, like a sweeping current and all, it has been considered quite less efficient. Okay, so frequency range, I always say people that keep your frequency range at maximum. That is how you can go for. So if you're keeping your base at 50, go for your spectrum, say for example 140 hertz, like that. For 100 hertz, let it go up and down. So that is even better. Okay, so choosing base is not a problem. Anything you can choose right from 50 to 100, no problem. But keep your spectrum, going up and down. That is better.
So it's totally about the accommodation. So it totally depends on the
it is
patient.
actually to break. Yeah, because what?
Yes.
Sorry, because what happened? The medium frequency current, right? So medium frequency current, when it is going through the 2 channels, it is easy to get accommodate. Okay, so this nerve sweeping has been this sweeping things brought only to break that this one, like what we say that this frequency, and this one base and spectrum has been brought to break that accommodation stuff, nothing else.
Got it, sir. Got it. It totally depends on the patient, and if they are way too sensitive,
Depend upon the patient and depend upon the physio. You can go ahead, you can choose one particular base, and then you can just select something like whatever you select, you should select in such a way that it goes easily up. And if I go a bit deeper into this, let me tell you, I have that sheet. I don't know where I kept. I'm not able to search it. There is something called skin impedance, right? We were talking something about skin impedance.
Yes, sir. Due to the dust,
little while back. Yes,
and all
it is
oils,
kind of resistance. Yes, it's kind of resistance. But let me tell you one formula. If you want, then I'll detail you. I have that whiteboard. I'll detail you. It's not there in this. Okay. Skin impedance is generally equal to half pi into fc. Okay, half pi value 22/7 in general. F is frequency in hertz, and c is the capacitance of skin, means the microfarad. We say capacitor is there, no, in the fan, in the everywhere we are using, no, condenser, what you say. So skin impedance is equal to like this. Now you can see skin impedance is generally like if it is high, means frequency will be less and condenser will be less. I mean the capacitance will be less. Okay, so say for example like capacitance of 1 microfarad, say for example. So if you, of course in India we have a 50 hertz alternating current, so impedance will come about 3200 ohm. But 4000 hertz, then 4000 hertz current, like that, whatever you have a medium frequency current, for that impedance will become coming what? You can calculate half pi into 4000 into 10 is to power minus 6. Okay, so that will come somewhere about 390 ohm. So what happened? This is how you have a frequency sweeping. Okay, so combined effect could be like what we say interference effect. I mean the beat frequency, what I told you. So working, if you see frequency of new this one, so suppose as I told you that time 3800 of red channel and 4000 of the black channel. So if you calculate for everything, then it will come
be
to
the beat frequency.
Resulted, but resultant carrying frequency, there is something called carrying frequency. I'm taking you a little higher concept. Carrying frequency is what? You add up both and then you take the average. Okay, so 3900 is generally the average of frequency. Okay, So there is something called amplitude modulation frequency, same like a sweeping one. Since you asked, so I was just searching in my laptop, but I don't get that paper. I remember a little bit, so I'm telling you. Interferential current, no, there is something called amplitude modulation frequency, AMF. What we were talking about, nerve sweeping kind of thing, right? So AMF is nothing. It is just like your beat frequency. You reduce that, and it will come 200 hertz. So 200 hertz then will be like a sine wave, and then it will work according to your this like placement of the electrodes. Okay, so this is how. But now, as you are asking about the base and spectrum, so like say for example this thing, say for example your beat frequency is 200 hertz. So if you set up your like a what we say that base at 50 hertz, say for example, and spectrum you are setting at about 100 hertz. Okay, so current will begin from the 50 hertz. Got my point?
Yes, sir. And it
You
keeps
got
on
my point?
fluctuating up
And
and
it will
down
go
from
up
50
to
to
the
100, 50 to
150
100.
hertz.
Yes.
Again, it will come to the 20 hertz. You got my point, man? So this is how we are actually keeping the like this parameter down. Okay, so it's about low frequency modulation where you are using this basic value. You are setting the base. So I always say people that keep the automatic like what we said, the base frequency at about 100 hertz. What is the beat frequency? Almost equal. You can understand for your clinical practice that beat frequency is like your base frequency only, like that. Okay, and spectrum you can keep it little higher. Okay, or if you keep little lower also doesn't matter. Okay, it will be rowing through that also I can tell you. Suppose you keep your base at about 100 and keep your spectrum at about 50, I'm telling you that it will go from the 100 hertz to little up to almost 140 150 hertz. Again it will come back like that, because the difference matters. But if you reduce a lot more, then it will not move enough in the machines. You will see that LED is not moving enough. So sweep timing parameter is very, very important. It sets the time period for this beat frequency to change from base to spectrum, like that. Base to peak. It goes to peak, again it comes back. So suppose you want your 100 hertz beat frequency, you can keep your base like 100. If you are keeping it 50 hertz, you should understand that your beat frequency is also 50 only. This is something you should keep it in mind, that much. Anything else?
Yes, sir. Nothing about IFT, sir.
Yeah. So whatever you are keeping in the mind, you just keep that whatever the beat frequency is there, that is your base. Keep in the mind, at least for clinical purpose.
So then when do we choose the Reeboks or the Russian current, sir? We
Okay,
also have
yeah,
machines
well,
of such.
yeah, yes. Russian current, if you're asking me, I'll tell you that any kind of person who are using for muscle strength, I have given that in the manual also. You'll get that where to get and how to use that. Okay, so it is for the yeah, it is for the strengthening the muscle part. Okay, Reeboks also for the strengthening of the muscle part. These all are the medium frequency current which has 2500 hertz. Okay, and Russian current I've been using even with the paraplegia patient. It maintains really the atrophy part, it reduces, and it actually gives a very good strength part also, I can tell you. Yeah, definitely it works very well. If you have a paraplegia patient, please use that.
Go for the Russian current.
Yes, go for the
Then
Russian current
how
rather
is
than
it? How is it different when you say it helps in strengthening the muscle? How is it different from the Faraday current? Because nowadays there are also evidences where you see that you can use the Faraday current on sportsmen. So, which is better effective according to your perspective, sir?
From my perspective, with evidence, I can tell that nothing can beat Russian current. It actually works very well.
Okay. Okay.
So it
okay. And then Faraday. And then Faraday current actually, of course, has some muscle re-education program, but it takes long time because of the low frequency. Longer time than the Russian current. Yeah. Yes.
Yeah, So I think yeah, we are running with time. No, we are 8:47.
So
Oh,
let's
I
wind
did not
up,
see the
sir.
time. Yeah.
Let's
Yeah.
wind up.
At 9 o'clock again, we have another program. Yes, yes, yes.
Yeah.
Fine with all your permission, then I'll be winding
Yeah,
up the program. The certificates and manual will be reaching you within
one
a week or 10 days.
one request. One request.
Yeah.
Yeah. So like all the participants, please try to give like one selfie video with the feedback. Okay. So and please update in the group only directly,
30
or
seconds.
we'll share
Enough.
the yeah 1 minute to like 2 minutes.
Yeah, whatever.
Yes. And we will share the feedback link also. So please update there also. Okay. Now, okay. Any doubts or any questions?
Please post in the group and then we'll answer.
Yes, yes, yes.
Okay.
Okay. So,
Okay, with your permission, Dr. Saurav.
Yes, sir. No problem.
So we'll conclude for today.
Thank you.
Yes.
Thanks a lot.
Thanks.
Hello. Hello.
Yeah.
Hello.
Sir, please share the recording also.
Pardon?
Recording, this session recording.
No,
I
no,
think you have
recording we are not going to share. We'll share the PPT.
if possible, please share the recording also.
No, no, not
So the
possible.
thing is, like, recording has some of the, like, it could be difficult. So we'll see.
No,
Only
no.
the PPT part can be done.
Yeah, PPT, sir. Okay.
Okay.
You can discuss anything through the WhatsApp or the email. No, no problem. Okay, sir. Thank you.